Hello, good morning. Or good afternoon.
Michelle, so we are not going to start, so thanks for doing.
Okay, thank you very much.
Good morning. Good morning, colleagues. Good afternoon, colleagues. Good evening, colleagues, wherever you may be. I'd like to welcome you to this webinar. My name is Ambrose Talisuna, and this is a different webinar from the ones we've been conducting. This is really focusing on the district level. But before we start, I would like to give our host, Bruce, to give a few housekeeping rules, and then we'll start with the session. Bruce, over to you.
Great. Thank you, Ambrose. My name's Dr. Bruce Struminger, and I'm with Project ECHO at the University of New Mexico, and it's really a pleasure to add additional welcome to everyone to this WHO AFRO update and guidances to country teams on COVID-19. Just a few housekeeping items. Most important, there is French and Portuguese interpretation. They're available via the translation button. Down at the bottom of the Zoom toolbar, you'll see an interpretation button, and there will be both Portuguese and French. Just click on the button for the language that you are looking for. Please turn on your camera if bandwidth allows. We're trying to simulate a face-to-face meeting, and we'd love to see you. Please keep your microphone muted during the session unless you've been asked to speak, and we will then unmute you, but please keep your microphone muted most of the time. If you can rename yourself with your name and organization, that would also be very helpful so we better understand who's here. Reserve the chat function on Zoom for questions and comments. That would be terrific. The session is being recorded and your attendance is consent to be recorded. So thank you very much for that. It's a very exciting lineup we've got of excellent expert presenters, and looking forward to the dialogue and to the learning. Thank you. Merci. Ambrose, back to you.
Thank you very much, Bruce. And colleagues, the previous webinars that we've had have focused on the technical side of the COVID-19 outbreak. As you are all aware, the COVID-19 outbreak is really rapidly spreading on the continent. Now we have over 16,000 cases in WHO AFRO, actually 16,425. Unfortunately, 753 of them have died. That's a case fatality ratio of about 4.6. As the outbreak spreads to the districts, to the provinces, to the communities, we really need to decentralize our response. And the focus for this webinar is really to help the district level people, the district level managers. And we structured it in a way that we will have a couple of presenters, and then we'll have a Q&A session. Our first presenter is going to be Michelle, who is going to give us the COVID-19 response in the African region. Then we'll move to a step-by-step setup of coordination mechanisms in the districts. And we'll look at activating the district rapid response team. And then we'll look at setting up a simple surveillance of COVID in the district. Surveillance is so critical. And then we'll look at step-by-step guidance on contact tracing and quarantine and isolation. After that, we'll have a Q&A session. After the first Q&A session, we'll then move to the laboratory testing strategy. The laboratory testing strategy is very, very critical. We have to identify cases, we have to detect them, we have to send some designated laboratories. So we'll look at the laboratory testing strategy. Then we'll look at intensive care management and case management. Of the previous webinar we had looked at case management. We'll look today as well in terms of how you set up isolation units and how you put it, how you set up an intensive care unit and what is supposed to be in there. Then we'll look at infection prevention in health facilities and communities. This is a very critical piece of work. And then we'll have another Q&A session. Then we'll do risk mitigation and community engagement. And then we'll look at logistics, supplies for COVID-19. And finally, we'll look at sustainability of innovative approaches for continuity of care in a decentralized health settings. Then we'll have the final Q&A session. So with those opening remarks, as I said, my name is...
Depois para uma sessão final de perguntas e respostas.
As the Program Manager for Emergency Preparedness. I would like now to invite our Incident Manager, who is Michelle Yao, to give us a broad overview of what we
are. Bonjour, bonjour.
And then we can proceed. Michelle, over to you.
Good afternoon to you all.
Bon après-midi à tous. C'est un plaisir.
Because the outbreak is moving out of the big cities, and in many countries we have already a community transmission, at least 10 countries in our continent, while about 22 of them have also many clusters of cases, and the remaining one sporadic cases that can easily move in the other different group of cases. So it's quite important for us to have an approach that will help us to have the capacity at the district level to perform the different response areas activities. It's including the coordination, how to set up a coordination structure. In some of the countries, we can have NGO partners involved in this response. And it is also important for the district official to ensure that they can easily kick off also the surveillance component. They can also set up the treatment facilities, mainly isolation facilities. They can also be involved in risk communication, as well as also community engagement, and they can also proposition or at least request for what is needed to this response. So the way the response is structured at WHO level is that we are structured around what we call the incident management system. And this system aims at having a clear command in the different response areas. The first pillar is information management that is critical. We have a component also related to what we call health operation, and then the other support pillars that are logistic, as well as administration and finance, and of course activities related to communication, to communicate about the situation, but also what is implemented. Let me just go now in a few points related to what is the actual the African continent. We are close. We are more than 7,000 cases with 1,200 deaths, and this gives us a case fatality rate of 4.7%. And we have, as I mentioned earlier, about 10 countries that have a community transmission, and we have then quite 20 others with clusters, and the remaining 21 with sporadic cases is where we have a great chance of also containing before moving into the next phase, that is the mitigation phase. The other point that I want to focus on is what are the countries, the most affected countries now, at least in the sub-Saharan part, including Algeria. We have Algeria. We have also Cameroon in the top 6, Cote d'Ivoire, we have also Ghana, Niger, and South Africa that are also presenting quite a number of cases. The other point that is also relevant is why the component like infection prevention and control is important, is that we have more and more health workers that has been affected. We have more than 200 health workers in the African region that have been contaminated, and most of them are related to poor infection and prevention control interventions in the health facilities. So it's one of the critical areas that also need to be reflected at the district level. So roughly, this is the situation. And the next step is as this outbreak will remain for a certain time, this is almost sure now based on evidence available. So we need to put in place a system that can allow us to continue the regular services to treat malaria as well as others, but at the same time to ensure that we have capacity to detect, to confirm, to isolate and treat people that are COVID related, at the same time providing the right information for preventive measure within the community and engaging communities to take the right action. So to do so, it should not stay at the capital level, but it should move into the district. So this training is the first step to this move. And this move is important. We need to keep the system running while managing effectively COVID. So I will stop here. Up to you, Talisona.
Thank you very much, Michelle, for those opening remarks. As colleagues, as you've had, really, no country now is spared. So we really need to be prepared to move out of the capital. So now I would like to our next presenter, and this is about setting up a coordination mechanism. And I would like to invite our colleagues, Patrick Abok and Brian, to present on step-by-step setup of a coordination mechanism and district at the district level. Patrick, over to you.
Patrick, unmute yourself.
Okay. Thank you. Thank you very much, Ambrose. I just want to ensure, are you able to see my slides? Oh, God. Hello, good afternoon, everybody. This is Patrick Abok. I'll quickly take you through some of the step-by-step of how we need to ensure coordination at the district level. And
Patrick,
then,
can you share your slides, please? Can you share your slides?
See any slides, please?
Okay, just let me share.
So Patrick, you'll just go down to share screen at the bottom. Great.
Are you able to see?
Yes, and just put it in presentation mode. So you'll want to put PowerPoint into presentation mode. There you go. Perfect.
Are we there? Okay, thank you so much. I'll rather be quick, and Brian will continue from that. I'll just be speaking on some of the key specific areas that we think we need to consider. Much of that, Michelle has spoken to that. As you realize that in most of the countries now, the outbreak has gone beyond the capital city into districts. Therefore, we really need to see how we support the member states on how they can quickly set up coordination mechanism at the sub-district level. So with this outline, basically, I'll want to focus on the rationale. Talking about the whole aim is to provide guidance to the district team on how they can effectively set up a coordination mechanism, with specific attention, of course, on the role of the district task force in emergencies. We also look at some of the core terms of references and lines of communication that is required along that line. We'll also look at some of the emergency management structure and the functions that are as required. The issue here is that why coordination in particular? We've noticed coordination is quite important because, one, it does provide us a common framework on how we can approach the emergency at the district level, given the fact that we have a lot of partners on the ground. and there's a need to tap in and leverage some of the resources available. Number two is to ensure that the district level, there's one plan for the district. So that means that a multi-sectoral team approach on how they can jointly plan, implement, and coordinate activities at that level. Thirdly, it's the issue of clarifying some of the roles and responsibility, given the fact that with COVID, for instance, now, it is beyond the health sector. It's involving almost all the government-wide approach. So it's quite important that the roles of the different players are well coordinated and well understood to ensure that effective implementation. And lastly, is to ensure that at the district level, we have both the vertical and horizontal coordination, mainly with the national system, but also at the district level and perhaps with other districts within the same vicinity. As Michelle mentioned, it is quite important that the district is able to focus as far as coordination concerned, one, on those issues that are specific to strategic aspect, and two, the operational, and then the three, tactile. These have to be very clearly outlined so that the various stakeholders within the district are in a position to play their roles. At strategic level, of course, it will involve issues to do with the task force, issues to the leadership, management, coordination, setting up some of the strategic guidance that is needed, but also coordinating with other coordination mechanism at district level. This can also include the disaster or the disaster management authorities, the emergency operation centers, to mention but a few. With the operation, first, of course, we will talk about now the level of implementation. Who are the partners and who is doing what? What kind of coordination mechanism there? Which activities are being implemented and how is this one implemented? And then certainly now you look at the soldiers themselves on the ground, the NGOs or the health workers who are actually implementing. How do we coordinate, ensure that there's proper coordination at their level and across the board? I'll run quickly to the next one. This one mainly is in terms of what is expected. So what I'll say here is that I'll run quickly through this, is that it's quite important that a system is set up that it's well coordinated and well managed. One of the important elements in setting up a step-by-step approach is ensuring that there's leadership at the district level. Once it's regarding to health aspect, normally it's at the district health lead that ideally takes up the leadership. But with COVID, we've seen it goes beyond health. So that means that that district level, there has to be a very clear leadership in terms of which department will actually be leading and providing the strategic guidance that is needed. Now, this leadership cannot do its role if it does not have a team to support. So the formation of the district task force team with clear lines of communication and terms of reference and deliverable is very, very important at this level. And these, of course, have also to be linked with the operational level, which mainly ensures that there are sub-functions regarding to the intervention in place. Some of which have already been mentioned. You can look at sub-functions regarding to clinical management, infection prevention control, operation support and logistics, but to mention but a few. The other important aspect is the issue of mapping, identifying and mapping of partners at that level, and also trying to identify their particular expertise and mapping this against the operational teams, and also in terms of the roles that needs to be done. So this mapping is very important at that level, and it should be based on actually who is doing what where, and also depending on their areas of expertise, so that wherever there are gaps, these gaps then can be filled. It also avoids the duplication and also ensures the equity into ensuring that the different geographical locations or vulnerable groups within the district are supported and yeah. The next step, of course, it will be important in terms of now the strategic response plan. This is quite important in the sense that if you are going to respond, how are you going to respond? what will guide or inform the decision to respond and in the way you're going to respond. So the development of a strategic
Como responder.
plan should be well costed, and it should also involve the participation of all the other stakeholders. So this plan will be used, of course, for various reasons. One, for resource mobilization. Number two, it also helps to guide those who will be involved in the operations, and also it will help in monitoring the progress to ensure that the key interventions that have been identified are supported and managed appropriately. So with that, of course, we know the district team does not sit in isolation. It is part of the national system. So a coordination mechanism to ensure that one, the response plan actually fits within the national plan, as well as within the district key clusters is actually harmonized. So clear link between the district and the national level, and also between the various departments and partners and groups at the district level is quite important at this level. Lastly, of course, if you do have your resource mobilization, the strategic plan, it is quite important that you start mobilizing resources. So this, again, is one of the key elements that is quite important for the district to be able to mobilize the resources and allocate them appropriately for the intervention. And lastly, of course, with the implementation, that means the districts have to set up a very clear strategy of collecting and disseminating information amongst the partners and also amongst the implementers. This is quite important, and it also includes information regarding to capacity assessment and situation analysis. But specifically coming back to the district task force, it is quite clear that this task force is formed, is well representative, and with a clear mandate. The structure is very, very important that you also should fit within the strategic interventions. Number two is that it's quite important that this team undertakes a timely and independent risk assessment. This will also include the needs and the capacity within the district, so that the interventions are based on evidence that are unique to the district. Thirdly, I mentioned about the response strategy, which should be multi-sectoral, which can also be used for resource mobilization or for appeal. Next is the issue to ensure that we're able to deploy sufficient expert and material resources to support the response. Not forgetting with the integrated disease surveillance that we have to ensure that the early warning, contact tracing, and response systems are in place. The task team, again, is also to support with capacity building efforts to enhance knowledge and skills of the responders, as well as setting up a robust performance monitoring and evaluation framework. This is just kind of a structure that, that we see mostly in terms of what Michelle mentioned, that can be duplicated and effected at the district. It's scalable, it's flexible, and it can be adapted according to the context in the specific district. As I mentioned, leadership, which involves the management structure, focusing on key specific functions, like we talked about coordination, information and planning, health operations, logistics, to mention but a few. Again, it's quite important that this structure focuses on key specific areas regarding to emergency management. One, regarding to the management aspect of that, two, operations, planning, logistics, finance, to mention but a few. The role of the incident manager or the team leader is quite clear. So as I mentioned, very important that clear leadership is ascertained that provides and supervises all the functional areas and ensuring that the fulfillment of different aspects of the incident management system. And lastly, of course, I'll say is that it's very, very important that this team works as one team in coordination and they're able to support the necessary interventions on the ground. So I'll briefly stop here and allow Brian to speak a little bit on some of the details on elements of partnership that's required. I'll be more than happy to take other questions. Over to you. Thank you.
Thanks, Patrick. Brian, please, could you talk about partnerships, please? Brian?
Ambrose, I'm not sure if Brian will join. He has been sick. So if someone contacted him to join?
All right, if Brian is not online, then I think let's proceed to the next, maybe the issues, if he comes back, or the issues that were supposed to be raised in Q&A. Patrick, please stay online because there are some issues that are coming up in the chat, and look at the chat for the questions that are coming to you. So let's go to the next presentation, and that is now myself. And let me see whether I can get my slides. I can't see my slides. All right, let me see that.
Great, Ambrose. We see your slides, but can you put that in presentation mode?
I think they're in presentation mode, Brian. Bruce, are they not?
Okay. We're not seeing it in presentation mode right now.
Okay. So colleagues, if from what Patrick has presented, now we really need to be moving to the role of the rapid response team. And this is really, we've adapted this from the IDSR guidelines, the Integrated Disease Surveillance and Response Guideline. And we want you, because you're at the district level, to go back to this. But before I go to the presentation on the rapid response team activation, let me just take us back to basic epidemiology. A pandemic from an epidemiological and delayed definition. So the pandemic that we are seeing now is the worldwide spread of an epidemic. We saw this in the 1918 Spanish flu, which was H1N1. We saw this in 2009 when we had H1N1 again. We've been having the pandemic of HIV, of course, and there are several others. But now, of course, we have this SARS-CoV-2, which is responsible for the disease that we now call COVID-19. The critical piece is really highly spreading. So many countries are affected. All continents are affected. Sometimes people use a lay definition of a pandemic as a scary infectious event that kills a lot of people. Look at the West Africa outbreak. People were calling it a pandemic. Actually, the West Africa wasn't a pandemic, but because it was very scary, some people actually were looking at it as a pandemic. But from the classical definition of a pandemic, it didn't suit that. What are the critical overall guiding principles here? It's unprecedented. What we are seeing is really unprecedented. We are seeing global economic fallout. We are seeing a global overwhelming panic. We are seeing fear. Actually, there is an epidemic of panic. And we need to address that. So we need to be able to health workers, especially at the district level, and deal with that. We need to avoid working under very stressful situations because we will make mistakes under stressful conditions if we're not working there. We need to increase and sustain teamwork because all the stressful situations, you really need to work and get some times off because once we don't increase teamwork, we're really going to burn out. Very flexible to adjust to this epidemic with several unknowns. But like Patrick was saying previously, we need to maintain a good level of coordination and ensure safety for all our team members. Safety for all our team members is a critical piece. Any health worker that we lose affects our response because that dents, it creates a gap. And so as health workers, we really need to ensure that we are maintaining safety of our team members. This is just what is the impact? Of course, high morbidity, we are seeing ill health. We are seeing high mortality, deaths. We don't even know what the socioeconomic disruption will be like. But there are also effects on mental and psychosocial aspects. Previously, we have done a webinar which was dealing with mental and psychosocial aspects for our health workers, specifically the nurses. But there is a big bit of mental and psychosocial effects.
Plan. Yes.
On families, on communities, and on health workers. But there is also a big impact on health systems. Michelle talked about this. We need to ensure that essential health services are continuing. We need to ensure that routine immunization is continuing. We need to ensure that the polio program is continuing. We need to ensure that malaria treatment is continuing. So as we plan the district plans, which Patrick was talking about, we need to make sure that essential services are also continuing. There is going to be an impact on travel, trade, and other sectors. The lockdowns, the non-pharmaceutical intervention. And this, of course, is also impacting for us WHO support to countries. For example, we have now to remotely support you when we could have been in the countries as such capacity. So let me, before I go to the RRT, just give you a few basic principles on why we want this outbreak to be controlled. In epidemiology, there is a basic concept called the basic reproductive rate, commonly called R0. When the basic reproductive rate is greater than 1, that means that one infected person infects more than 1, 2, 3. COVID-19 is about 3.4, actually it could be up to 5 people could be infected. The outbreak will continue. Our intervention measures are to ensure that an infected person infects less than 1 person. And so the outbreak dies out and is controlled. This is the basic notion for diseases for eradication, for example, for like polio, where you want to make sure that the basic reproductive rate is less than 1 and the disease gets eradicated. That is the notion that we need to move to a basic reproductive rate of R0 is less than 1 for COVID so that we can contain COVID. But we really don't know how long this is going to take. The new COVID strategy update has 5 critical pillars, which I really want to remind you about. One is find, test, and isolate cases and quarantine contacts to interrupt transmission. Provide clinical care and maintain essential services to reduce mortality from COVID-19 and other non-COVID-19 diseases, events, and conditions, as we call them in integrated disease surveillance. Adapt strategies based on the risk, capacity, and vulnerability. We need to suppress community transmission. We need to transition and maintain a steady level of transmission. We really need to reduce transmission so that we can control the outbreak. We need sufficient public health and medical interventions in place. We need outbreak risks. We need to address the outbreaks in special settings, in slums, in crowded urban areas, in communities. And we need to engage communities. And that's why this afternoon we'll be dealing with risk communication. And we need to address COVID-19 in humanitarian settings and high-risk groups. And there is a WHO guidance on addressing COVID-19 in humanitarian and high-risk settings. So these 10 steps of setting up the rapid response team at the district level, they are actually adapted from the integrated disease surveillance and response. Please look at your edition booklet 3 in both English, in French, and Portuguese. One of the first steps is before you need, as a district, you might get a rumor, you might get an alert. The first thing you need to do is to establish whether there is an existence of an outbreak, because some of the conditions present with symptoms similar to COVID-19. So when you receive a rumor, a report from communities, from social media, from the media, you need to be able to verify that. Review the data and determine if it is a COVID-19 outbreak. Is it occurring? Conduct preliminary data analysis. Collect additional data over the phone if necessary. Verify the suspected cases and see whether it's definition. Review the influenza database on clinical case definition if there is no COVID-19 confirmed in your district. Now then you need to do a step 2 where you prepare for fieldwork. You need to identify the rapid response team members and prepare the required logistics, including epidemiological forms, case-based reporting, line listings, and other gadgets for monitoring temperature, lab collection of samples, and Belinda will be talking about this. You also need to collect additional information on the alert of the case, and this might be over the phone if you probably in some scenarios. But we also need to communicate to all reporting levels. One of the issues we are seeing in COVID-19 is the reduced reporting. The international health regulations require us to report rumors because it's part of event-based surveillance. And this will help us to investigate. Now you need to mobilize your public health emergency rapid response team. And in the integrated disease surveillance and response guideline, we call this public health event risk rapid response team. So before embarking on the COVID outbreak investigation, there are issues that you really need to put in to prepare. Prepare the team with all the appropriate information and data about the suspected case so that everybody knows what to look for and what precautions are needed. All team members need to be refreshed about the symptoms, about the case definitions, about the modes of transmission. COVID-19 is droplet transmission. It's not airborne transmission. It's not like tuberculosis. It's not like measles. So if you have a mask, you probably prevent droplet transmission. Now, if you're going to, you could have a surgical mask. What diagnostic tests are you carrying? And importantly, personal protective measures and the containment, early containment. You need to mobilize the public health emergency response team and make a prompt investigation on every alert. And the alert we are saying within 24 hours because it's the only way we can respond in time. The rapid response team must be multidisciplinary, and I will be coming to the composition shortly. And then you really need to have an overall district coordinator who is working with all the other relevant staff to be identified. And if they have not been identified, we need to train them like yesterday. We need to be training them like now so that every district train rapid response team. What are the key functions on the rapid response team? It's advisable that you have a database of trained people. So we are saying even the districts that don't have a case as of now, you need to train people who are going to serve on your rapid response team. Somebody has to be on the rapid response team that plays a coordination function. That is the leader. You have somebody on the rapid response team that has an epidemiology and surveillance function. You have a laboratory function on the rapid response team. You need case management function on the rapid response team. You need infection prevention and control on the rapid response team. You need environmental health and sanitation on the rapid response team. Actually, we need social science and anthropology on the rapid response team because we need to understand how communities are going to be addressing this. Actually, we are encouraging this to ensure that we are understanding how communities are responding. You need to have a risk communication and community engagement function on the rapid response team. You need to have a mental health and social support on the rapid response team. You need a logistics function on the rapid response team. And actually now we are even encouraging to have a security function on the rapid response team. In resource constrained settings, some team members can fill more than one function. You might not have each of these as an individual, but there must be somebody playing that function. Because if we don't have somebody playing that function, it will fall through the cracks. So what is the IDSR, Integrated Disease Surveillance, saying of the composition of the rapid response team tailored to COVID-19? So you need a team lead who is going to play the rapid response team. This might be the district head, the district health officer. It might vary from country to country, but you need to take a decision on that one. You need a clinician who will oversee the case management function. You'll need an officer, could be a public health nurse, to oversee the infection prevention and control function. The public health nurse to oversee the sanitation function. Surveillance epidemiology officer, data manager, laboratory scientist or laboratory technician, a social scientist somewhere, risk communication. These might be health officers in some districts, and we are encouraging for COVID-19, really we need somebody we need to be working with mental health and psychosocial support for health workers, for communities, for individuals. And most of the planning for COVID-19 is logistics. It's epidemiology, but also logistics. If we can't have things in place, however good our epidemiology is, the logistician is as good as the epidemiologist and each of these critical functions, because we don't have things in place, you don't have PPE in place, you don't have masks in place, then you can't move. So logistics is so, so important, and security. Before moving to the field, really we need to be reminding the members of the guiding principles. You specify the tasks of each of the team members, what they're expected to do. We define the supervisor and communication lines and decide where the investigation is going to take place. Require, if you need any authorizations, make sure that these are done. And this is really, we are making this is field-based, practical. This is not, it's field practical issues. We've done trainings, webinars on the technical issues of COVID-19. Make sure you have all the forms, case-based forms, line listings, contact tracing forms, because if those are not there, that's why we're not getting line lists from the countries. The logistician and the transport people should be able to transport people, and you are transporting with physical distancing. So you must be looking at how many people are traveling in one vehicle, because you're not going to crowd in a vehicle, in one vehicle when the country recommendation is saying you should be physical distancing. So you should be physical distancing even when you're traveling to the field. And then make sure that Belinda will be talking about this. Make sure that you are ready to go and collect samples, and those samples will be quickly transported to a designated referral laboratory where they ensure adequate personal protective equipment. So the roles, I'll tell you, it's really every district, every sub-district should have a rapid response team. If you don't have that as of now, as a country, make sure that these are trained now. We can support that remotely with a training package for rapid response team to respond to rumors, alerts, to coordinate and respond rapidly, to initiate implementation of interventions even before the national level comes in. And with COVID-19, we are seeing that actually we might work on your own because the national level might not come in very quickly because there are travel restrictions as well. So the district has kind of to be decentralized and in a position to be able to function on its own with limited support, might be remote support from the center. And that's why we really want that the district level is working like that and has the capacity to do that. Propose appropriate strategies and control measures, and the control measures will be looking at that, especially risk communication, and prepare investigation reports and then evaluations. The third and fourth step is really verifying, and this is really classically from IDSR. We've just adapted it to verify and confirm the diagnosis. And those are the steps that you need to do. You'll get these slides. Define the cases and their contacts and search for additional cases. The next session is going to be dealing with case definition for cases, suspect cases, probable cases, confirmed cases, and what's the definition of a contact. Collect maximum information from the contact, even if they're in a quarantine, and their relatives, because once they transform to cases, you need to trace those contacts, and that is really very, very important. You need to be analyzing the data, and we are really encouraging that really we know where the case is coming from. Is it children? Is it females? Is it males? Which are the places that are most affected? And when? Because this is going to help you to make intervention measures, but also to inform the neighboring districts. And using the cases you're seeing, you need then to make a decision on whether you are seeing sporadic cases, you are seeing clusters of cases, or actually you are at the most extreme case where we are dealing with community transmission. We are encouraging countries to do what we are calling the COVID clinical characterization protocol. We don't know in Africa what this outbreak is, who are the most affected, which comorbidities will affect outcome. So we're really encouraging countries that we participate in this COVID-19 clinical characterization. How do people with malnutrition respond? How do people with tuberculosis respond? How do people with HIV respond to COVID-19? So we need to be able to do clinical characterization. And as we really encourage you that once you do this, we need to do the clinical characterization. Steps 7, 8, 9, and 10. You then need to implement containment and risk mitigation. And ultimately, for every good epidemiologist, you need to write a report and disseminate your findings. And then do further risk assessment to see whether the outbreak has spread to other districts, because you need to be informing those districts. And finally, you need to maintain an intensive surveillance. And this is really going to be the next presentation. But in conclusion, colleagues, we are health workers. We know from the Spanish flu, which caused millions of people. We've seen this in Ebola in Africa. Now we are seeing it with COVID-19. If we don't put these measures in place, we will regret. And as a continent, we need to do this. COVID is showing us we need to be prepared. We need to quickly respond. We need to quickly mitigate the effects, its effects. But a really cautionary note for us as health workers. The duty of us as health workers is to protect lives, is not to lose our lives or to lose our health while caring for patients. The loss of a health care worker dents our response because other people are going to die. We must be able to protect ourselves, because if we don't protect ourselves, we actually affect the response. So personal protective equipment, if you need to go and investigate and you really think it's a high risk patient, you need to be going with protect yourself. The district rapid response team needs to have all the knowledge, the skills, and the supplies to be able to safely investigate COVID-19 cases. So the key element for you at the district level, contact tracing, early detection of cases, early confirmation and isolation of cases, and quarantine of all high-risk contacts. If we do this, colleagues, we could be able to contain this outbreak. If we don't, we'll be leading to mitigation, and mitigation will have many, many severe consequences. I would like to thank you, and I would like to stop there and invite our next presenter now, who is going to talk about surveillance, and then we'll take a few questions. So colleagues from the surveillance team, please, over to you. Frank and, Charles.
Yes, Charles will start with the surveillance, and then I will present the contact tracing part. Okay, Charles, go ahead.
Yeah, thank you, colleagues. But just to note that I failed to log in, and I'm making the presentation through WhatsApp. I need to know whether the voice is okay before I proceed.
We hear you well.
Are you getting? Is it clear?
We can hear you very well.
Charles,
yes,
go ahead. We
Charles,
can hear you.
Clear.
Just put the slides in presentation.
Please, Frank.
Yes.
Learning objectives.
Learning objectives. Okay. Good.
Up to the end.
Yeah.
The presentation is going to cover the objectives and key components of COVID surveillance, case detection and alert management system for COVID-19, what to do when a suspected COVID case is identified at district level, data management for COVID-19 outbreak, and reporting and documentation. Next slide.
Yes.
Up to the end.
Yeah, it's okay.
So the key objectives of COVID-19 surveillance are: 1, to rapidly detect new cases that may emerge in a district or any location. 2, provide epidemiological information that is used to perform risk assessment at all levels, but also to guide our preparedness and response interventions. And lastly, we want to monitor how the disease is spreading within our location. Next slide.
Go ahead.
So there are 5 major components of COVID surveillance that need to be established at district level, and we need to ensure that all these components are working effectively. Number 1 is a system for case detection and alert management. Number 2 is a system for case investigation, and this relates to the previous presentation made by Ambrose. Rapid response team, their major function is case investigation. The third component is a system for contact tracing, and you're going to get a presentation on this. The third aspect is data management at district level. This is important. And the last one, which we always forget, is reporting and documentation. We do a lot of work. At the end of it, we do not report. To an external person, we have not done any work the moment you are not reporting. Next slide.
Yes, okay.
So when you talk about a COVID-19 case detection and alert system, there are 2 major elements. One is the actual case detection of cases actually occurs at the facility level, at community level, and at points of entry. We need to ensure that all these facilities, all these reporting points have well understanding of the case definition of COVID. We have the suspected case, the probable case definition, and the confirmed case definition. You will get the case definition in your slides. I'm not going to run through them because of time, but I think we are pretty clear about the COVID case definition. We need to ensure that case definitions have been disseminated widely, and healthcare workers are very conversant with case definition. We have got several issues of health facilities reporting what they call alerts, but when you verify, they simply do not meet the case definition for COVID at all. And in that, you spend a lot of time following issues that are not of significance. So we need to adhere to the case definition for COVID-19, especially the suspected case definition. So all our health facilities, community structures, for example, community volunteers, needs to be oriented on a simplified version of case definition to ensure them to identify cases at their level and report to the next level. The next aspect is what we call an alert management system. We are going to be getting information from various sources, from formal and informal sources. If we do not have a systematic way of managing this information, it becomes difficult for us to follow this information and track them. So at a district level, we need to establish what we call an alert management system. And primarily, it does triages all the information that comes, it verifies and validates them before referring the cases that meet the suspected investigation team to go and investigate. Next slide.
Yes, okay.
So the next slide is a schematic diagram of an alert management system at a district level. I'm not going to go into the details, but the most important thing to note here is that you need to establish an alert desk, and the alert desk should have a minimum of 2, preferably toll-free phone lines where people call in from all places. And I'm talking about district level. I know most of the national response system has already established an alert management system at the national level, but this has to be replicated at the district level. Because if you are relying on the national alert management system, all information goes to the national level, then it has to be relayed back to the district. You're going to lose a lot of time. So at this time, we need to ensure that every district has established a functional alert management system. and you can follow the flow diagram, how the alert management system will work. Next slide.
Yes, okay.
So primarily at a district level, you are going to detect cases from mainly two sources. Number one is at the health facility. Number two is at the community level. Community means maybe there are various places that can be categorized as community. So as a surveillance officer, from a surveillance standpoint, when you identify a suspected case at a health facility level, I'm not going to run through all the things that you see in the slide. But the key things that you need to undertake is that you need to fill the case reporting form, especially for cases that are occurring at the beginning of the outbreak in a district. You fill case reporting form. You're probably going to fill case reporting form for 10 to 15 to 20 cases, then maybe you can consider stopping. And this takes me to constructing a line list. From the beginning of an outbreak in your district, when you fill a case reporting form, transcribe that information into a line list. We have provided to you a line list template, which is actually automated. We encourage you to use the automated line list template. So pick the information from the case reporting form, fill it into the line list. It is very important. It's going to help you in your subsequent data analysis. Then number 3 is you need to conduct an active case search. When you identify a case in a health facility, look for more cases. You look for more cases by doing records review, but you can also look for more cases actively. You go if you have an inpatient ward and find cases that meet the case definition. But in addition to that, you need to identify contacts. The rest of the other things in the slide you will read. But from a surveillance standpoint, the 3 points I've picked are very important for you, and you need to ensure that you do them. Next slide.
Go ahead.
In the event that you have detected a case in the community, then you need to organize that community. And now this is all into what Ambrose has said, the rapid response team. From a surveillance, as a surveillance focal person, you will be part of the rapid response team. So when in the community, you need to interview the case and the community members around that case. Number 2, you need to visit all the places that the case has traveled actually before 2 days before onset of symptoms. Whether the case has gone to a church, whether the case has gone to a traditional healer or has visited a relative. You need to go to all these places. What are you going to do in all these places? You are going to look for more cases in all these places. That is 1. But number 2, you are going to identify and also list contacts. The process of identification and listing contacts you will see in the next presentation. So it is very important. When a case occurs in the community, you need to visit that community. And as a surveillance officers, the 2 points I've highlighted, you need to take note of. The other people in the rapid response team will perform their functions. Next slide.
Go ahead.
Go up to the end.
Yes.
This is a schematic diagram of what rapid response team at district level will do in terms of investigating the case. Ambrose has already talked about this, but this will give you the specifics of what you are going to do. So I'm not going to go through this slide. You'll take time and look through it. Next slide.
Okay.
Now, so we have talked about case detection and alert management system. We have talked about case investigation that fits into the rapid response team. That third component is actually data management. You need to establish at the district level, as part of the surveillance pillar, a data management team. It depends on the country. In some countries, you will get an epidemiologist at the district level. But if you don't have an epidemiologist, a surveillance officer is at the district level. Part of the data management team could be data managers. In some countries, you have biostatisticians, you have HMIS officers, you have record officers and data clerks, etc. It is important to have a dedicated team that manages data at the district level. Now, the team should ensure that all data collection and reporting tools are disseminated to all facilities. If facilities don't have tools, you do not expect them to give you the data that you want. So you need to ensure that the case reporting forms, the line list templates, even if it is paper-based, the line list template is provided to the facilities. Contact listing and follow-up form are provided. Now, you need to establish a database at the district level. The automated line list that has been provided for you can help you to serve as a database. But that means that you're going to collect reports from all the facilities and put them together in that automated line list. This is particularly important. Then you perform epidemiological data analysis that is going to inform the response. And there are basic elements that you need to do. Person, time, and place analysis. Who are the people who are getting sick in terms of age and sex? What are the symptoms? What are the risk factors? At district level, if you find difficulty in analyzing risk factor, don't bother. As long as you have captured that information in the line list, the national level will help you to do the analysis. Then, EPICAP. The good thing with the automated line list that has been provided to countries is that it will generate an EPICAP automatically. The moment you feed in the variables in the line list, the EPICAP will be developed for you. So you'll just extract it, and the surveillance officer or the head of the epidemiologist will just extract the information and go and make a presentation to the task force. But also, you need to do a place analysis. You can do a spot map even if you are drawing it by your hand. Which place has been newly affected? People need to know that and roll their interventions to those places. So data management is very important. You need to establish a data management system at the district level. Next.
Yes.
I say that oftentimes we do a lot of work, but we forget to report about what we have done. In this COVID outbreak, you need to produce the following reports, and they are actually mandatory. You don't just say, no, I'm tired, I'm not going to do a report. You need to do a report. Every day, you need to write a situation report at a district level, and this should be submitted to the national level. And what goes into the situation report? You need the AP status in that district. You need to summarize the key actions that have been taken. And you need to highlight the major gaps and what you require at the district level. And send this report to the national level on a daily basis. You can agree with the national task force how this report is going to be transmitted to the national level. But to accompany this daily situation report, the line list that you have compiled should be submitted. the line list that you have compiled from all the facilities that are admitting COVID-19 cases should be submitted alongside the situation report. And this is very important. That is why I'm emphasizing. Then, for every new case, especially the initial cases that are identified in the district, you need to write a short case investigation report. Or if you get a new clusters of cases, or if a new area has been affected, you need to write a short investigation report. Reporting has been our biggest problem. People do a lot of work, but they do not take time to summarize what they have done and submit it to the next level. I think this is a summary of the surveillance functions for COVID that needs to be put at the district level. And I really want to emphasize again that you need to establish a system that detects cases, but also an alert management system that coordinates all these cases, because cases are going to come from various places. You need to thoroughly investigate the cases that are identified. Then you need to set up a system for contact tracing, and you're going to get details about contact tracing. You need to set up a data management system at district level and provide the reports that already described. Thank you very much.
Thank you very much, Charles, for that presentation. Please stay online because I can see questions that are coming in on some of the issues that you might need to deal with. Now let's move to step-by-step guidance on contact tracing. Contact tracing is so important. So Frank, please, over to you.
Okay, thank you. We shared this morning technical guidance on contact tracing for COVID-19. So I will give you an overview of these documents because we will have time to go through it and try to implement what is in, because it's a really step-by-step guidance on contact tracing. As you know, COVID-19 is transmitted through contact. So if we want to break the chain of transmission, establishing an effective contact tracing and follow-up system is key, especially at the district level, at the lowest level of the health system. So the objective of the contact tracing system is to early detect cases among contacts. That means we have made all the necessary effort to identify around each case all the contact. Will talk about how we can make sure that we are not missing some contact around cases. So the objective is to early detect cases among contacts and then early isolate them and start early also providing treatment to those contacts. And the final objective is to reduce transmission, so break the chain of transmission and increase survival rates among cases in your districts. So, as principle of contact tracing, let's start by saying that we are going to monitor, to follow up contacts, not only for confirmed cases, but also for probable cases. When we look at some situation report, some of the countries are reporting probable cases, and they have raised some issues on whether they should follow up contact for probable cases or not. This is just to specify that if you have probable cases, you should also list their contact and start following them using the same principle as for the confirmed cases. So while you have your contacts, you should classify them into two groups, the high risk contact and the low risk contact. in the document, you have provided the definition of high-risk contact and low-risk contact. So it is critical because if you become overwhelmed with several contacts, sometimes you can just start focusing on those of high risk. For example, if you are losing some contacts are lost to follow-up, and you are trying to make effort to search them and find them, at that time, it is important for you to start focusing on high-risk contact. So it is critical for you when listing contact to specify which type of contact this contact had with the case, so that you can classify him into high-risk or low-risk contacts. So on the right here, we have described the process of contact tracing. It started at the time that you identify a case. A case can be identified in the community or in the health facility. So as long as you identified a case, result of the investigation, you should list his contact. It started by mapping the path of the case 2 days before the symptom onset till the day he will be isolated. So you should describe when he passed through. So at each place, identify with which person he has been in contact and what type of contact they had, so that you can classify into high risk or low risk contact. So this is key to start listing seriously contact, because if we miss listing contact, this contact will come up later on as confirmed case somewhere, and we don't know to which case these cases are linked. That is the time we start losing control of an outbreak. So if you identify your contact, sorry? Okay, if you identify your contact, you should follow them during 14 days, which represents the maximum incubation period. So the diagram describes when the contact becomes symptomatic, what should be done, and it's in the document that was shared with you this morning. So this is the content of the step-by-step technical guidance. It provides the definition of contacts, contact of confirmed case, probable case, level of risk, high risk, low risk. It also describes the process of listing contacts. So in the document, we specify that when you investigate a suspected case, you should establish a pre-list of contacts, and we provided the tools on how to list contacts. But the contact is listed preliminary by the investigation team, but the follow-up will be done by the contact tracing team. So you should organize a proper handover between the investigation team and the contact tracing team. Both should have time to identify contact, visit the contact, take their phone number, explain to them how the contact tracing will be implemented, provide leaflet with all information on what the contact should do or what the contact should not do during the period of follow-up, especially provide information on how he is going to follow the quarantine. So it's also in the document some guidance on how the person should, what is the role for him when he is supposed to be on self-quarantine during the 14 days of follow-up. Then we have the contact follow-up itself. We propose several approaches that can be adapted according to each country, which include first the self-reporting. We know there are several countries that have started to implement self-reporting. It can be through SMS. You can ask each contact every day to send some key information. He's still living in the place where you record his address, what is his temperature, what symptom is he feeling, some symptom, and so on. It can be directly sent by the contact. You agree on the time, or for I saw in Niger, they are sending questions every day to the contact in his mobile phone, and then the contact will reply to the questions. That's also an option. We are also working with the GIS team, who is proposing a tool also that can be downloaded on the phone, and then every morning with his code, the contact could provide information on his health. So that will be the first option, because it will reduce it will prevent for the contact tracer to go every day and visit every contact, which will be impossible if you have a huge number of contacts. So the second option is phone call. If a given contact did not self-report, then you will wait at a given time and agree with him. Then you can call him to check if something is wrong or not. What also was suggested in the guideline is that for those contacts who are complying with self-reporting every day, you need twice during the 14 days of follow-up, you need twice to go at home and visit him and check if the information is sending is really true, and check off on his health status. So lastly, when the person did not self-report, you try to reach him on call and did not succeed, then you can organize a home visit. But you know that according to the scenario, some countries can just decide that they want to visit every contact every day. But we provided 3 options, because with the lockdown, it could be difficult for countries, even at district level, to organize home visits for every contact. So in the document, we have also a section where we describe the condition for discharging a contact after 14 days of contact. You need to take into consideration where the person is living. If in his home there is other contact who are still under follow-up, you need to take that into account. Some countries are testing contacts. So we advise also, if you want to test contact, which will be the best time for you to test the contacts. Maybe if you test him at the beginning of the follow-up, you need to do it a second time when you will discharge him. So we suggested that you test the contact if it's in your policy, you test him between day 12 and day 14, so that when you get the result, you can decide on discharging the contact or not according to the results. So there is also there in the document human resources requirement in terms of how many contact tracers do you need, how many supervisors do you need, how many epidemiologists to oversee the overall contact tracing system you need. So the principle we described there is to have 1 contact tracer for 10 contacts to be followed, and 1 supervisor for 10 contact tracer. So at a district level, you can have 1 epidemiologist to oversee all the process of contact tracing. So there is also in the document a section where we describe how you can adjust your contact tracing strategy to the transmission scenario, starting by 0 case. If you have 0 case, that you can have 0 case but have contact. We have it in one of the country. They have cases a case by which is in another country. So that case have contact in the country, but the country has 0 case. So they have also to organize contact tracing for that contact, even if they have 0 case. So for sporadic cases, maybe they can do home visit for all the contact, but from cluster to community transmission, it could be difficult to visit all contact. We specify also in the document that when you have a large community transmission, sometimes it could be difficult to continue following contact. So national authorities can decide to focus contact tracing only in newly infected areas and improve at that time active case funding. This is an option also for countries, depending if they can continue to monitoring each contact or not. So the document has also one section on how to manage a contact that develops symptoms, because it becomes symptomatic, and then we use the alert system that was described by Charles. Finally, in the have proposed also tools that can be used to manage data on contact tracing. The first option is to use paper-based. That means each contact tracer will fill every day a paper form that will be collected by the supervisor and bring to the data manager at district level, and the data manager will use the contact tracing tool we shared with you. Many countries are using that tools, but we notice that it is not well felt. Especially, people do not understand the concept of day 1 to day 14. Day 1 is not the first day you start monitoring the contact. Day 1 is the days following the day of last contact with the case. Meaning, if you start following a contact, you start following him 5 days after the last contact with the case, then you should fill day 5 and not day 1, even if it's the first day for you to meet with the contact. That's why we are not able to analyze some of the contact database we are getting from countries. We have developed also a user guide that can help you to better use that contact tracing tool. That's the first option. The second option is to use ODK. We have also a questionnaire developed, ready to be deployed in any country using ODK. It has 2 components. One questionnaire for contact listing that includes basic information on the contacts, and then the second questionnaire with just a few variables is the questionnaire for daily monitoring. So if you have it, we have also a script developed that can help to analyze data and provide information on necessary indicators on contact tracing. That's the second option. The third option is to use the GIS polio platform, which also for data collection use the ODK system, but it comes with a nice dashboard, and it's also easy to be deployed quickly. So it is being used currently in Zambia, Zimbabwe, Congo-Brazzaville also will start using the GIS polio platform for contact tracing. So the last option we provide in the document is using GoData. But GoData requires some expertise in its deployment. So if some countries like DRC, where we have people who are already familiar with using GoData, they can also use GoData for contact tracing. It's the more complete tool among those I've just talked about. That's what I had to share with you about contact tracing. You have the document, you can go through it, and if you have questions, we are ready to answer at any time to help you improve contact tracing at district level. Over.
Thank you very much for that presentation on contact. And colleagues, this contact tracing guideline has been shared, and I can see in the chat people are asking questions about it. So we will send it through the country representatives, and then they should be able to reach you. So please, also the people who have been on this call, when we share the slides, we can also attach the contact tracing guidance document because we want it to be widely distributed. Now it's time for question and answer time. I have some themes that I've captured. I hope, Bukari, you've captured the questions in French. And then we will have some discussion on, and then I can see Kaba has put up and he wants to say something. So Bruce, maybe you might see how we can allow one person to ask a question, Kaba Mohammed. For you, Patrick, the question of for forming a district task force. About, do we have guidelines for setting up a district task force? And then I'm going to read through the questions, then each of the panelists we will respond to them. Will WHO provide a unified monitoring and evaluation tools to the countries? And then is it efficient to have the same definition for household, for health facilities, for social contracts? I think this is to the last two. The next, some questions are on lab. So those ones on lab, we are having a session. So Belinda will talk about them, but so I'll skip those ones on lab. And then there is a question, what do we do with contacts of asymptomatic patients? Should we ignore or should we follow them up? Contacts of asymptomatic patients, Frank, you need to respond to that.
Exactly.
What is the rationale for including contacts, secondary contacts in the contact tracing? What is the rationale for including secondary contacts in the contact tracing? And then contact tracing by electronic means might not provide adequate information. Can you comment about that? And then the question by Alex Chimbaru, at what level, what do we do? Is there a threshold for stopping investigation? Suppose we get cases beyond 100, 1,000, what should we do? And then there is a question about the prototype of a line listing, which else you need to talk about. And then I think I'll take a question from Alemu Wondi, who said, we need some leadership on slowing or slowly down because there is a lot of panic. So I'll take that one. So, and the final one is, I think those are the ones that I captured. So, Bukari, do you have any questions in French that you want to summarize so that the presenters can take this question? And we'll start from Michelle in that order. As you presented, that's how I want you to respond. So, Bukari, can you summarize some questions? Then we can allow the panelists to respond. And then if Kaba can be allowed to ask a question directly, that's also possible. I'm asking Bruce to see that we can do that. So, panelists, we can start with, let me start with Bukari.
Yes, you can proceed with panelists. I'm still checking.
Okay. So let me start with Michelle. Michelle, do you have any answers to those questions if you're still online? Patrick Abog.
Yes, Ambrose, thank you so much. I think in terms of the guidelines, what we have is something that was developed for the national level, but it can be adopted for the district level. Following this this session, that means that we can go quickly into the mode to adapt them for district level to be shared with the team. Over.
But also to add, Patrick, that in the IDSR guidance, there is a guidance on how to set up a district epidemic committee. So I think it's part of the task force. So the guidance on the incident management system and on the task forces, I think, are there, so we can just share the template for you.
Yeah,
Okay,
actually, that is true. And what we need to do is to ensure, because much of the guidance is a guidance, that means they're generic. Different countries have different contexts, which means that they basically need to adapt. What is quite important is that we need to ensure there's a linkage with the national system for the purposes of ensuring the resources reach out to the districts, and then there's also accountability on both sides. Over.
All right, so Charles, and you had a lot of questions on surveillance and contact tracing. So can you respond to those, Charles and Frank?
Charles, can you start?
I didn't get the question clearly. Can you repeat?
Okay, it looks like most of the questions are on contact tracing. So let me reply to those questions. The first question is about contact of asymptomatic persons. It's in the technical guidance. We recommend that we have to list contact of asymptomatic cases starting 2 days before the date of confirmation till the date of isolation. So during that period, if the person has been in contact with anyone, those persons should be listed and follow up as any other contact, because when someone is saying asymptomatic, we cannot make a difference between the mild case and the asymptomatic one. So the advice is to list contact 2 days before the confirmation, because we don't have a symptom onset date, 2 days before the date of confirmation till the date of isolation. So about the secondary contact, I did not really understand the question, but what I can say is contacts are contact of cases. So if I'm a contact and I became a case, the same rules will apply to me to identify my contact, and then identify them and start following them. So the principle is we are not listing contact of contacts like we were doing it for Ebola, but contact of contact for Ebola were listed for vaccination purposes. So here we are listing contact of cases. So if a contact became a case, we list his contact. Electronic tool. In fact, electronic tool is developed using the paper forms. So it just turns paper to electronic. So the same information that is in the paper will be reflected in the electronic tool. Like I said, if you want to use OGK, the kind of questionnaire we develop is based on the paper forms, with one questionnaire for listing contact with all the necessary informations, and then one questionnaire, a short one for daily follow-up, and we have a system to merge those two databases to do the analysis and provide all the indicators for contact tracing. I think that was the only questions for contact tracing.
Charles, you needed to say something about active case finding in the context of community transmission. Active case finding in the context of community transmission. Charles, do you want to say something about that?
Okay. Active case finding in the context of community transmission. Actually, when there is widespread when there's widespread community transmission, the best approach at that point now to the question would be, how would you do active case finding when down the question?
Charles, we can't hear you.
You can use a number of approaches. but one of them is you move from house to house. Cases. You can use volunteers to specify case definition. They move from house to house looking for any case. If there's a case in that house, the case is escalated to the team that comes and investigates. So yes, it's actually the best approach to do when there is widespread community transmission. In that situation, contact tracing becomes very cumbersome. So you resort to looking for cases active. I think it's the best approach now. Over.
Thanks very much, Charles. And you're coming in from phone, so we didn't hear you clearly. But I think, yes, and I think the guidance document on contact tracing says in the scenario of widespread community transmission, contact tracing might not be feasible. So the shift on when you reduce contact tracing and shift to active case, detecting cases and isolating them becomes the critical piece of the work. I also want to inform you that there is a 3-pager on COVID-19, which is going to be added to Section 11 of the IDSR guidelines as a new disease, which has some of the information that some of you are asking. We are going to share this also once we have it translated. The question on, suppose you have beyond 1,000 cases, Alex Chimbaru, I think their case-based reporting becomes a challenge, and the guidance as of now is that you shift to aggregate reporting within every 24 to 48 hours of reporting, because the numbers are overwhelming and case-based reporting becomes completely a challenge. So those are some of the things that you adapt as the outbreak shifts. I hope we don't reach there, but if we do, then we probably will have to reinforce that case-based reporting becomes a challenge, because you can't report on every individual cases. We need to be reporting aggregate data, but structured by age group and where they're coming from geographically. In terms of relaxing lockdowns, this came from Alemu Wondi, my senior colleague Alemu Wondi. I think he's saying that it was because of the panic that we have sent out a guidance document on the step-by-step way of what you need to consider to relax measures. These measures, and then to observe the scenario, a risk-based assessment, observe the scenario. If cases resurge, then you put back the measures. So it's a step-by-step, and we look at the cases in the last 2 weeks. Are the cases reducing? Are the numbers reducing in the last weeks? And there are measures of us to be able to track the reduction of cases. Then you step back and we relax the most extreme measures, which is likely to be like lockdowns, and step by step you might relax mass gatherings, and step by step you might reopen schools. And if there is a resurgence of cases, then the measures go back. So there is a guidance document which I invite colleagues to read on a step-by-step relaxation of those measures. The prototype line list is there, the database is there. Charles just needs to share this with you. So we hope that you'll get these. At what level should community leaders be involved? I think community leaders should be involved from the beginning. Once you have a case in the community, you need to involve community leaders because they are part of the response. So it's really not good to keep data from community leaders. So as quickly as possible, community leaders should be involved. Those are the ones that we have, colleagues. The ones on diagnosis, Belinda is coming, so I don't want to preempt Belinda's presentation. So with those, I would like now to move to the next topics. And we have 3 topics, then we have a Q&A. So we will start with laboratory testing, and then we do intensive care unit management, and then IPC, then we have a Q&A session. So Belinda, please, over to you. Belinda,
can you enable me to share my screen, please?
All right, Bruce, can you allow Belinda to share her slides, please?
Okay. She can share her slides.
Yeah. Okay, good afternoon, everyone. I'm going to try and talk as slowly as I can. So I'm going to talk about what the role of the laboratory is and what is needed at district level with regards to laboratory. And this links in with both the rapid response team and what your surveillance goals are and the epidemiology, and also links in with, contact tracing. So the laboratory is basically used to detect infection and to confirm infection in an individual. And most importantly, what the laboratory needs is a quality specimen to get a meaningful result. So that's an important thing to think about. And so currently, there are two types of assays that can detect SARS-CoV-2 or COVID infection. One is a direct assay, so that is looking for the virus directly. And so the assay that is the gold standard at the moment is a PCR or a nucleic acid test. So this is quite a complicated assay and it may not be available at the district level. The other type of assay would be looking for viral antigens, and there's a lot of talk about RDTs or rapid diagnostic tests, and these are being developed. So a test that detects viral antigens is an RDT, and so it will look for some part of the virus that's in a patient specimen. The other tests that are available and come under the rapid diagnostic test umbrella are those that detect antibodies. And so those tests will detect either IgM, IgG, or both IgM and IgG, or some can detect IgA. So, and once again, the antibody tests are still under evaluation by a large number of regulatory groups. Some have been approved or emergency use only listed by the US FDA. Okay, so when we go, say, to the district level, what do the people need to know and what do they need to do? And so this then links in with your rapid response team. So what you would need to do at the district level would be collect specimens. And so your surveillance officers are going to identify people who fit the case definition, or this may be part of the contact tracing of collecting specimens from contacts. So the first thing you need to think about is what PPE you will be required and have that with you, and also the specimen collection materials. There is a process for collecting specimens, and in the training package for the district, there is a video on this, and it is in a number of languages, and it's in Portuguese as well. The other thing you're going to need is documentation. So as Charles mentioned, there's a case investigation form, and on the case investigation form, there will be a laboratory section. So when the specimen gets sent to a laboratory, it needs to have some kind of documentation with it, predominantly the case investigation form or a laboratory investigation form if you have developed one of those at country level. So then you may need to ship or transport the specimen to a testing laboratory. And if you have a testing laboratory with capacity in the district, it may be there. If not, it may be to your laboratory at the national level or an international laboratory. So all COVID specimens go as the UN 3373. So this is not the same as Ebola. So the conditions for shipping are not as stringent as you would have for, say, Ebola specimens. So the equipment that you will require in the district will be triple packaging. And then, yes, you need to think about where to send it and what are the conditions. So most specimens will be sent with cold packs at 4 degrees. And so there's a number of things in the slide set for the districts about how to send this specimen and who you need to contact. So the final thing is that in the district, if you have access, you may be detecting or testing for the pathogen. So this is using the manual assay or PCR, and for that, you would require specific training. And so as the lab pillar, we are developing videos and training components to do training virtually. Or in the district, you may be doing an automated assay, say, for example, the Gene Expert. And for that, you would need to consider what PPE and conditions you would need for specimen handling. And we are still working through what would be the best guidance for that. The other thing that I wanted to point out is that the Gene Expert cartridges aren't available yet, and I will provide more details to the wider group about when and how access to Gene Expert cartridges will occur. The other thing you need to think about is who to test. And who you're going to test is going to depend on the four scenarios, or the four scenarios that Charles has talked about. So where you have no cases and you're looking for cases, whether you have sporadic cases and clusters of cases, or whether there is community transmission. And this is also going to be based, who you're going to test, based on what capacity and what resources you have. So these are things to think about when in your country you're developing your testing strategy. And it should be developed, in conjunction with the case management and the epidemiology groups. And your testing strategy may differ based on the location where the outbreak is, and also the scenario that you're in. So say in a major city, you may have community transmission, but you may have a new case in another town, in which case you would then you would develop your testing strategy based on the sporadic cases. So all this is in a document. The web address is at the bottom of the screen. If you have limited resources and capacity, you may want to look at prioritized testing. So it may be in areas with no circulation, in settings where there's limited resources. That's just some ideas on prioritized testing, and this is also within the document, that web address. Some alternatives for testing. I'm not going to read through this because you will get the slides, and it's also within the document. And just to give you a hint on how you would do this. So the first thing is you're looking at what is your transmission scenario, and then looking at what you're going to do with that patient, because it may be that there's sporadic cases and you need to do testing contacts. It may be in community transmission, and you just decide that you're going to base diagnosis on the case definition rather than test. And so this infographic just gives you an idea of what you could do, or what might be the scenario if depending on what resources that you have. And so this was based on these two documents, and these are the two key documents that you need to look at to develop your testing strategy within your country, or testing strategies, depending on the three different situations that you may have in country. And that is all I have. Thank you very much for your attention.
Thanks very much, Belinda. Please stay there. A couple of questions for you, and we will go to John. John, quickly on what is your subject, John?
Management.
Care unit, case management. John, are you online? John?
John, maybe you are muted.
John, please unmute your microphone and go ahead. Over to you.
Can you hear me now?
Loud and clear. Thank you.
Okay, thank you. Okay, so basically, we want to go through what intensive care is about at the district level under case management. But I would like to run through other aspects before we narrow into intensive care in this limited time as much as possible. There are other terminologies that you can use to refer to as intensive care. Intensive means requiring extra care aside the regular monitoring, aside the regular treatment that we give to our patients. So high dependency unit, critical care units, they are all the same as intensive care unit. Looking at hospital readiness to manage cases as a whole under case management, we will have to have a triage procedure in place. WHO recommends that at the first contact of potential patient or patient client visiting us, we need to be able to screen them and then sort them out into patients who potentially could be COVID cases So this must be in place at all our emergency departments or where patients we come across. Once a patient qualifies to potentially become a probable suspected case, what you do is you isolate the patient and then you initiate triaging to assess the degree or how severe the patient is ill. But before you do this, let me stress, and we have had quite a number of healthcare workers who have been exposed and who have fallen sick. So it's very important that you put on your PPEs, which at this point in time, we recommend face mask. Face mask should be enough face masks should be enough at this point in time to use to care for the patient. You maintain a distance of about 1 to 2 meters as you care for you manage the patient. Doesn't mean that you don't go closer to the patient, but if you have to offer something like oxygen, for instance, nasal prong, you have to get closer and then manage the patient. Patients who don't need this are also offered a medical mask for the purpose of the safety of other patients. Now, for the hospital readiness, we need to identify and we need to be sure that there are signs and also there are equipment available for medical care of the suspected and then confirmed cases. We need to have isolation unit, and at the district level, we need to create these spaces to be able to receive care for our patients. Certain procedures, not all patients that we'll be able to care for at the district level. Some of them might have quite severe cases that at our level, we cannot care for them at the district level. So we should have procedures of how we move patients intra-facility and then inter-facility to be sure that patients receive the right care that they need. Also transporting diagnostic samples, we need to make provisions for that. Training of our workers. One of the key things, and I'm sure the IPC team will stress, that it's very important that we all get to know how to use our protective equipment, from face mask to the full donning of all the protective equipment. Even hand washing, universal precautions, we need to be trained in that. So as a district case managers, you have to be sure that this has been provided for your health workers, and they understand each step of the way what they will need to do. Now we look at specifically intensive care. When we talk about intensive care or critical care or your high dependency unit, it's comparable to your ICUs for theaters. So if you have a theater, you are required to have an intensive care unit. You are required to have an ICU. It's the same thing we are requiring here, just that the patients here are not post-surgical cases. So please let's understand those who have that. Those who do not have that, you can create a small corner where your severely ill patients will get the extra monitoring, the extra care. Within this unit, they will require a lot of nursing care, a lot of medical care. So you have to provide the number of nurses, the number of doctors to be able to do that. Aside the human resource, you also have to ensure that the basic equipment that is needed to care for the patients are there. So monitors. Most patients coming to us will be mild cases. Even in some cases, we have asymptomatic or pre-symptomatic cases. Both pre-symptomatic and asymptomatic cases must be monitored till they are more than 14 days after exposure. What we know and what we've learned from elsewhere, China, Italy, or Europe, and then United States, is that we talk about patients who suddenly crash. This is because their saturation gradually goes down, but it's not noticed over a long time, like days. And then suddenly they become breathless and show up to us, and then we think that they suddenly deteriorated. It was not sudden. If you had monitored them maybe a few days before this, that would have been done. So aside that, those who are monitoring or treating for mild and then moderate disease conditions, we'll have to also ensure that we check their pulse oximeters, which is the level of oxygen in the blood. If they are breathing room air, that will be a major indicator and one way of treating most of our patients. Again, in an ICU, you need a blood gas analyzer. I know this is quite big in some situations to ask for in the district facilities, but then it's very important. If you don't have the blood gas analyzer, as for pulse oximeter, every district level should have pulse oximeters available in your high dependency, even in your general ward, so that you can manage them. When you check the vitals, pulse oximeter should be one of the vitals that you need. In terms of the functionality of a high dependency unit, you would require a multidisciplinary team approach. It's not a one-man show. You need people from different areas to bring their expertise. Our concern is the elderly. Our concern is the comorbidities. For the few countries we have looked at on the continent critically, these are the cases developing very severe disease. Even though in the other age group, like the 30 to 40 age group, we have some cases that have turned out to be quite severe. So we have to look at the age, we have to look at comorbidities like diabetes, like hypertension. These potentially can quickly go into decompensation and crash in front of you. So if you are mindful of that, even those with mild diseases, you should keep them in the hospital and then monitor them till they go through and they become safe at this point in time. Now, when we talk about critical care unit, what actually we are talking about is supporting patients who require organ support. So one of their major systems, like respiratory system, like the circulatory system or the cardiovascular system, is not able to function adequately to provide what the patient needs to stay alive. So ICUs where these, the treatment for these patients occur, and that they need frequent monitoring. They need an hourly monitoring to be sure that we are not missing anything and the patient is not deteriorating. As the next line says, it's advisable to have these at the teaching hospitals, the fully equipped ones, but in some isolation centers where you build a prototype isolation center in your provinces, your districts, they must at least have all these equipped, one facility or two facilities, depending on the patient workload, should be able to have this. I cannot overemphasize the importance of oxygen. COVID management now is oxygen, 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 oxygen. For the severely ill to the critically ill, that is the way to go. There's no other way, there's no better option than these ones. If we pick those who are severely ill early and we initiate oxygen therapy, we might not need to look at ventilators. United States and then other places now, they are slowly reducing the rate at which they put patients on ventilators, because patients who get on ventilators are not coming off ventilators. If you put a patient on a ventilator, it should be able to do other things. But CPAP, just like this machine, the box that we have here, the patient lying down, it's a very simple machine that can be used anywhere. You can use it at your district on one bed a patient lies on. It's a very simple process. You put the mask on the face, you turn it on, automatically this works for the patient. You can add oxygen to it, and then the patient will get all the required treatment. So patients who don't want to go to higher centers, which I know quite a number of patients, when they are comfortable with the district level and they don't want to be referred, we need to look at providing them with this. So now talking about the non-invasive ventilation, I've mentioned CPAP. The other option is to have the high flow cannula. The regular oxygen interface delivery equipment that we have can deliver as much as only 15 liters per minute. So if you have the nasal prong, for instance, the highest you can go is about 10 liters per minute. There are two types of face mask when delivering oxygen. One can go as high as also 10 without the reservoir, and another one has a reservoir which you can use. The reservoir you can give as high as 15, and 15 liters per minute can deliver 100% oxygen. But high flow nasal cannula can deliver as high as 40 to 60 liters of nasal cannula. Apply a little bit of pressure. I just described the CPAP, which is a non-invasive ventilation earlier on. But again, as I said, we are the recommendation now from anecdotally, this is not published anywhere, but conversation with other colleagues, it's very important that you delay putting a patient on mechanical ventilators because these patients who get on mechanical ventilators are not getting off it. If you want to put a patient on mechanical ventilators, you have to make sure that the room, or both non-invasive and mechanical invasive ventilators, you need to make sure that where you care for these patients are well ventilated, that there's a lot of airflow to move potential aerosolized viruses out of the space. The staff must have airborne precautions. So at this point in time, if you are thinking about ventilatory support, CPAP, high flow, invasive, intubating the patient and ventilating, then we have to up our precautions to airborne protection. So this is where we use our N95 mask, and then you don your gown to be able to be sure that you are well protected. We cannot overemphasize that. If you are at the level where you can provide mechanical ventilation, these are the recommendations. I'm not going to go through everything, but at least what we are going to do is what we refer to as lung protective ventilation. Already the lung is sick, you don't want to damage the lung, so you watch your tidal volumes, you watch the pressures at which you ventilate the patient, both the plateau pressure and the driving pressure. These will be required by intensivists, the critical care specialists, and then the anesthesiologists. They understand what we are talking about. But the positive end expiratory pressures, we have to be careful. CPAP use a form of positive end expiratory pressure, but it's not too high to damage the lung. So let's have this understanding. Other ventilation strategies which is being used elsewhere, helping patients get off the vent. In the United States, if you talk to colleagues, they are doing what we refer to as proning. Proning means turning the patient and the patient lie on the belly. So here, even if the patient is not on a mechanical ventilator, it helps with aeration of the lungs. Most of our lung tissue is at the back, it's not in front. So if you lie at the back, the weight collapses part of the alveolar, leading to atelectasis. So what you want to do is that you turn the patient at the lying on the lying prone for 12 to 16 hours, and these patients are turning out to do well. But doing this requires a lot of human resource, and we need to look at that. Neuromuscular blockage, I'm not going to go through that for those who are on mechanical ventilator. Nitric oxide is a no-no in our management. The other aspect of critical care that I want to talk about is shock and fluid management. So two types. If a patient comes with shock, shock is different from daily maintenance. So you resuscitate patient who is in shock. The recommendation is that shock means poor perfusion, cold, fast, steady pulses. These are signs that tells you that your patient is in shock. The treatment is to be conservative. Don't give too much fluid. We recommend for the adult population that you give about 250 to 500 mL fluid bolus. After giving 1 or 2 fluid boluses, you turn your attention to vasopressors. Don't keep on giving fluid. Say, oh, crystalloids did not work, so I'm going to blood, I'm going to FFPs. These are not recommended. In fact, they don't have any additional benefit as outside what the crystalloids like Ringer's lactate will give you. For vasopressors, it's recommended that we use noradrenaline. If that's not there, you add adrenaline to it. For maintenance fluid, which is the patient requiring fluids for the next 24 hours, so you have to be conservative. What we do is that just give about 80% of the maintenance fluid that the patients will require in a day. So we are not going to do the 100, 100, 100 or 75, 75. Work out the total fluids in the normal volume, let's say 3 liters, 2.5 liters, work out 80% of the volume, and then give the patient over the 24-hour period. ICUs are noted for complications, major complications. You don't want your patients to come out cacated with nourished. So feeding is very important. The early you start feeding your patient, the better it will be for the patient. If they cannot feed, you pass NG tube and provide enteral feed. Analgesia is very important for patient mental status. If you want to avoid delirium, IC delirium, analgesia and sedation, you have to be measured in giving them. The chances that patients are going to develop thromboembolic complications are very high in COVID patients, even in the younger population. So we need to be aware, mindful of that, and provide therapy to prevent that. Always have to elevate the head of the bed to prevent ventilator-associated pneumonia or orthostatic pneumonia. You have to start mobilizing the patient early. We need to provide cover for ulcers, bed sores. Turning the patient is what we need to do. My last point, my last message is that be careful about the patient's blood sugar level if you are managing the patient yourself. Stay within 4 millimoles per liter to 10 millimoles per liter. That is the recommendation in ICUs, and that's where my talk will end. If you want more of this, what I have summarized, you can get this from the WHO website where the publications have provided this link. So if you want a quick look at that, you can go there and have a look. Thank you very much.
Thank you very much, John. And participants, one of our panelists for the IPC is not feeling well, so we will move to, we will do this session in the next webinar. So the session on IPC in health facilities and communities, the panelist is not able to present because she's not feeling well. So we'll just now go to the Q&A. So that gives us an opportunity to have a couple of responses to some of the previous questions. I hope the other panelists are not still on. And maybe Bruce, you might allow 2 people from the participants to share their experiences. I can see some people who have raised their hands. Let me know how that goes. Belinda, there are some questions for you. Is mass screening useful for countries with no cases? One question for you. 2, which John or Belinda you can take. Is the COVID virus active in dead bodies? How long does the virus stay in the dead bodies? And then for the previous presenters, can you isolate someone with breathing difficulties? And is there a role of influenza surveillance, sentinel surveillance sites to improve COVID-19 case detection? This is from Sierra Leone. And how does immunity to COVID, how long does immunity to COVID last? I don't even know whether we can answer that, but somebody can check on that one. What is the value of doing 2 tests? This is to Belinda, nasopharyngeal and oropharyngeal. And then, is there a specific rapid diagnostic test that is being recommended? And what is the best place to quarantine cases? And again, what is the sensitivity of PCR? What is the usefulness of serology tests? And somebody from Zambia says there is mass COVID testing in Zambia using rapid diagnostic tests. Accuracy is 65%. Can you comment about that? And what is WHO's position on rapid diagnostic tests at the district level? When will cartridges of GeneXpert be available? Is taking a single swab adequate? There is a shortage of swabs. Or is there a video showing how to take an oropharyngeal swab because we want to watch the video and be able to improve our skills? John, you might comment about, please specify which masks should be used, FPP2 or N95, and which days do we test asymptomatic quarantines, and what is the status of reagents for other automations like Abbott 2000, and I'll take this one from Bio. How can member states, WHO partners use COVID-19 for health system strengthening and IHR to sustain the gains we have made? And the final one is, when do you shift from case-based reporting to line listing? This is for, I think, for Charles. At what threshold, what are the numbers should you shift to case-based reporting to line listing and aggregate reporting? Those are the ones I captured. Unless, Rubukari, you have, I will then allow, because we have some time to We'll take some more questions before we go to the next session, since we have one presenter who is missing. So, Bukari, do you have any questions that I've missed?
Most of them are comments. There is one question on, I think it is for Frank. He's asking if we ever face with resistance. If yes, during contact tracing, if yes, what is the strategy and advice to country? And another question is about the incubation. After how many days after the contact with the virus that you can identify it in the oropharyngeal? This is in fact the incubation. The rest, there are comments on the self-isolation. Some people are saying that it is not working in Africa because people have to go and look for and do their daily work. So there are only two questions: incubation and the resistance to contact tracing.
All right, so let's have the panelists start. Belinda, I'll start with you because you have a mouthful, and then the other panelists will answer. Then John, and then I'll answer Bio on health systems and international relations. Belinda, please.
Okay, hi everyone, and thanks very much for all your questions. One of the questions that Ambrose didn't pick up, what I did see, was about the virus in stools. So one study that I have seen shows that virus is actually shed in stools, and that's by looking at viral RNA. But you shed a lot of viral RNA in stools just normally, and in this study, they weren't able to virus. Oh, I'm muted by the host. I'm unmuted. Can you hear me now?
Yes, we are hearing you.
Yes. Okay. Right. So I'll start again. So I was talking about stools, everyone's favorite topic, and shedding of virus in the stools. So one study shows that virus is actually shed for quite a long time in stools, but in this study, they weren't able to recover any viable virus. And one thing to think about is that you shed a lot of, you can recover a large number of viral sequences from stools in a normal person. So it may be that the virus shed in stools is not viable. The question about dead bodies, viruses need to live in cells. So if the cells aren't alive, the virus won't be alive. It would probably be about the same time as how long the virus can last on a surface. And if you think about on a surface, if you have a moist environment, an enveloped virus will last longer than a dry environment. So if you are, and this question came up about wanting to swab a dead body. So the suggestion was to find out how long how long ago the person had passed away, and then to try and get a throat swab if there was still basically some fluid in the throat. So there was one question about the sensitivity. The sensitivity of PCR depends on what test you're using. So each different PCR test may have different sensitivities. The specificity is usually close to 100%, but the sensitivity will depend on the test. And also whether you pick up infection from a person is going to depend on the timing when you take the swab, how well the swab is taken, and and the transport conditions. So there's some things that you need to think about with regard to positivity of patients. With respect to the question about one swab or two, if you put 2 swabs in one vial, then you're going to get double the amount of virus. So it will increase the probability of detection if the specimens are taken well. But you can, if swabs are short and you have somebody who is very good at taking swabs, then one swab, either oropharyngeal or nasopharyngeal, should be sufficient. Where am I up to? The availability of the reagents for the automated platforms. This is an ongoing work with many teams at HQ looking at consolidated procurement, and we have a meeting on Monday, so we'll have more details after that. It's still a work in progress, but we're hoping to get some tests out the door maybe next week or the week after. What were the other questions? So the question about shedding. So generally people, so the incubation period, I believe, is about 1 to 6 days. You generally start shedding virus before symptom onset. So you may be able to detect virus in asymptomatic people 2 to 3 days before symptom onset. And that's if they're going to have symptoms. If they're going to be mild cases with no symptoms, then there's going to be no sign that when you're going to take a specimen. So that's that. The other hot topic is rapid diagnostic tests. The rapid diagnostic tests there's a lot on the market. Some are better than others. As you've seen from the data from Zambia, the accuracy is around about 65%. The accuracy of influenza rapid tests, I think, ranges from about 35% to 80%. So the sensitivity of them is going to be probably around about the same. One of the issues with rapid diagnostic tests is that people do not develop antibodies to this virus until perhaps 1 to 2 weeks after they have been infected. So if you were using this for mass screening, you wouldn't be potentially missing a lot of positive people because they haven't developed antibodies yet. And so some assays are for IgG only, which will detect a convalescent infection. So maybe when you've finished all your symptoms, the other tests are IgM, which is an acute phase antibody. So when you're undergoing your acute infection, you produce IgM to detect that. And some look at total antibodies. So both of those together. But it still doesn't avoid the potential of missing people who haven't produced antibodies yet, but are still infected with the virus. The position of WHO is that at the moment, these aren't recommended, but they're recommended for doing, say, serological surveys or for surveillance to look at people who may have been infected, so large population studies. But for clinical detection and patient care, they're not recommended. Is there a top rapid diagnostic test? There are a number that have been qualified for emergency use by various regulatory agencies. So as I mentioned, the US FDA have one that is emergency use listed. And I think the Korean Ministry of Food and Drugs they have listed a couple of 1 or 2 rapid diagnostic tests for use. So there is information about the rapid diagnostic tests that are around and then which regulatory authorities have approved them for use in their particular country. Have I missed any questions?
I recall if you have missed some, I'll come back to you. But John, you had some. John, can you talk about the types of masks and some questions that they raised? On influenza surveillance, Belinda, you could comment about influenza surveillance, sentinel surveillance to improve COVID-19, because this is also your area, please.
So do you want me to speak now before John?
Yeah, speak now before John.
Okay, so sentinel surveillance for influenza certainly can play a role. In the countries that have sentinel sites set up, the case definition for COVID and for influenza is not that different. So if you're picking up, if your influenza surveillance is ongoing, you could collect the specimens for the people who fit the influenza case definition and also test them for COVID. So influenza surveillance does have a role, and for those countries that do have sentinel surveillance set up, I would recommend that if you're testing people that are captured for influenza surveillance, that you also test them for COVID. Over.
Thanks, Belinda. So, John, could you say something about how long do you think about immunity to COVID-19? I don't know whether you can take it or we just, please, if you then comment about the types of masks and also Charles or Frank, if you're there, what kind of quarantine facility should we, where should we quarantine people in Africa? So I'll start with you, John, then Charles and Frank, and then I'll end up with Bayo's question on broader issues of preparedness. Over to you, John.
Thank you, Ambrose. Thanks for the questions. They are very important questions here. Let me start with, I also got picked a few from the chat box, and let me start from the question asking about, do we isolate patients with breathing difficulties? Yes, breathing difficulty is one of the major signs of COVID. We are not saying every patient with breathing difficulty has COVID, but potentially can be a case. So that patient must be isolated till proven otherwise and managed accordingly and appropriately with oxygen. How long does immunity last? We are still learning from the virus. In fact, we got to know about the virus just about December last year, depending on which information you look at, November, December last year. And we are into the 5th, 6th month of the virus being found. What we know is that just like any other immune disease and the patient's response to immune response to patient's inflammation, when the virus gets into the system, it takes a few days, up to about 7 days, for the body to start producing antibodies against the infection. And from there, it peaks around the 14th day. That's the initial antibody response, the IgM. And then following that, the second form of antibodies are produced, and that's around the 14th day. And also peaks around a week later, and then sustain a little bit. In some cases, it wanes over time. In COVID, we don't know exactly how long the immunity lasts, and that's the challenge now. We just have a short, as I said, we just had a short experience with COVID. So we all need to learn from COVID as the months and the weeks evolve. So no one can tell you exactly whether you are going to have a long-term immunity, lifetime immunity at this point in time. We don't know. No one knows the answer to this. The other questions which was directed to me, prophylactic antibiotics. Prophylactic antibiotics for COVID virus itself, no. There is no antimicrobial for COVID virus. All other treatment being tried now are on trial research basis, and it should be given in that context. Unfortunately, quite a number of places in Africa, we are using chloroquine to treat that. There's no proven efficacy. The data, jury is still out. We are waiting for studies being conducted. So we have to temper the way we give chloroquine. If you have to give it being able to monitor for side effects. And that's very important, or you can give it on compassionate grounds. So that would be the question. But if there are differential diagnosis, I think this is a community-acquired pneumonia, an infection somewhere that you have to treat, by all means, go ahead and give your antibiotics if they are needed. FFPs and N95, they are the same. FFP2 actually, so FFP2 actually is a terminology used by the Europeans, and the Americans use N95. They are about the same. Prevents 95% of droplet infection. So your risk of exposure, that's how it's reduced. Isolation and quarantine, having all of them in the same place, that is quite, potentially can be a dangerous practice, because quarantine, it doesn't mean that your client or the person has the infection. You just want to look at the patient, monitor the patient if the patient doesn't have the infection. So if you mix them with patients who are isolated because they have the infection, potentially we can create problems for them. Samples from upper or lower airway if the patient is intubated. Remember, suctioning from the ET tube going down is an aerosol generating procedure. Even basic sample taking is an aerosol generating procedure. So if you can get your sample from the upper airway easily, even intubated patient, which we can do all the time, please stick to the upper airway sampling taking. Oxygen concentration. As I said, treatment of COVID now is about supportive therapy, oxygen, 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 giving the patient time to build immunity to remove the virus from the system. The source of oxygen is not as important as the oxygen that you are given. Once you have oxygen from any source that you can have for your patient, by all means, go for it. If it's a plant that you fill bottles or cylinders to provide your patients with treatment, go ahead and get your bottles, fill them, use your flow meters to deliver. If it's not, and you have what you call oxygen concentrators, as someone has reminded me, it's very important at the district level. Please use that. There are kinds of oxygen concentrators. Some can give as high as 10 liters per minute, 5 liters per minute. So please, these are quite important therapies for patients. So, and I think I've covered the questions I have seen at others.
And Frank, there is a question from, there's an additional question I've just got from WR of Niger. I think one of you could take on that. They are seeing a lot of asymptomatic cases with rare and atypical symptoms. They are really saying we might need to review the case definition so that we can test those contacts of people who are either asymptomatic or are typically. So Charles and Frank, you have to comment on that one because, and then John, before you go off, is there a possibility of reinfection? And what is the benefit of use of vitamin C? And is there any use of convalescent plasma? So John, before you go, you first do those case management one, then I go to Frank and Charles to respond to my senior colleague WR of Niger. John.
Yeah, so possibility of reinfection. We know that in South Korea, in China, in other places, yes, and even in Africa, here we've had a few places where questions have come up in such cases. Let me take it one at one, two different kinds. The first one is the patient has been cleared of the virus and then tested positive later. South Korea, there have been examples. In China, there have been cases like that. In the case of South Korea, what we know or what we think, again, we are still learning. We don't know everything, whether these are reinfection or reactivation. So basically, we are not exactly sure where they are. And their infectivity, we are also not very sure whether they are infective source of infection. But still, we have to treat them as potentially source of infection till proven otherwise. So we have to be careful. There are cases that patients up to 35 days have not cleared the viruses from their system. And this is a major concern, both in China and a couple of cases in Africa. How to manage them currently, we are not sure how to go about it. In China, for instance, one of the cases for or let me say, not only in China, but in such cases, we have to provide them with psychosocial support, because one of the Chinese cases, for instance, was talking about killing himself. It's very important that we manage such cases very well. Sorry, Ambrose, what were the other questions?
Use of convalescent plasma.
Yeah, use of convalescent plasma. Yes, I know one or two places or one or two cases they have tried convalescent plasma, but these are anecdotal reports. We don't have fully published research that should guide what we do, but these are dire times, trying times that people are trying everything that they can lay their hands on.
And benefit of vitamin C. I mean, vitamins are really good. So
exactly. Yeah, vitamins
are for your health. So just
it helps you build your immunity, but not necessarily COVID-specific treatment. Thank you.
All right, Charles and Frank, are you still online?
Yes, I'm still online. Charles is disconnected. But yes.
What is the best place to quarantine cases? And then there is a question, should there be isolation facilities in quarantine facilities? So those are two questions. And then I think those were the only ones that came for you.
Yeah, yes. First
and
question.
Asymptomatic.
Yeah, asymptomatic, yeah.
Yes, yeah.
Okay. So maybe for cases, we use isolation of cases. Quarantine, maybe the question is more for contact. What is the best place for quarantine contacts and not cases? Is it for cases or contacts?
What is the best place to quarantine? That must be quarantine of contacts, of course, yes. You quarantine contacts, you isolate cases.
Yeah, exactly. So for contacts, our advice based on the guidance is to have, if possible, quarantine contact at home. And we provide some instruction on how to organize the quarantine at home. If possible, the person should have his own room, keep social distancing with other people. It is in the document. So if the government want to find a place where you want to quarantine contacts, maybe it's his own decision, but he must take all the IPC measures to make sure that people will not get infected while they are on quarantine. That's all I can say about quarantining contact. The WR of Niger has just sent an email complaining to the fact that all the presentation and discussion are in English. So I will respond to his question in French. So pour les cas asymptomatiques, c'est vrai qu'il y en a.
For asymptomatic cases, it is true that we observe an increasing number of those cases. We are not going to change the definition of cases based on the fact that you have asymptomatic cases. The case definition has the aim of helping to detect quickly cases. If you see that the definition is based on the fact that somebody has fever and symptoms, and in your own experience, you notice that most of your patients have fever, then you can adjust the definition, the case definition. But then, if you want to detect more asymptomatic cases, then you need to have a strategy in place to help you detect the cases before they develop the symptoms and isolate them early. Same thing when it comes to resistance. If you suggest contact tracing to some people may resist to that. In some countries, you will see that the first people who were infected are from the middle class. Others are of the higher class, and they do not want people to know it or to come visit them. This is why we need to adapt the strategy so that we do not have to visit the contact every day, because that person will see somebody visiting every day. So we need to start with distance monitoring, telephone calls, and visiting when calling does not work. This is the reason why we also said that there needs to be a process to identify the contact. This is in that identification phase that you need to establish contact with the contact. What can the contact do? What should he or she not do? And you should have help from the specialist in risk communication. Thank you, Frank.
We're trying to support you as much as possible. So we'll send you all this information presented today in the slides will be translated. There was a question on when do you, at what caseload do you move from case-based reporting to line listing? I think this is really, we shall just use basic principles. In my experience, being even at the country level, I think when cases exceed like 1,000, then it becomes very difficult to do case-based reporting, and especially if they are very rapid, they are occurring very rapidly. So you have to look at it on a case-by-case basis. If you have more than 1,000 cases and you really not, case-based reporting becomes a problem, you move to aggregate reporting and also maybe line listing. Bio, my colleague in WCO Uganda, how can member states, WHO and partners use COVID-19 for health system strengthening and the international health regulation and to sustain the gains. This is a very valid point. Ebola in 2014 and 2016 led to reforms both in how WHO was addressing health emergencies with the creation of the WHO form, and then a revised international health monitoring and evaluation framework, which involved both the JEs, after action reviews, simulations, and exercises. We really think that what COVID-19 has demonstrated is that preparedness across the board, across the world, in developing countries. So this is really a health systems issue, and I agree with you. We have now to start now advocating for building these public health functions, capacities of the international health regulations that are really linked with the health system strengthening. We just had a call the other day with the DDG, and this is really the thinking now. So it's a valid point, but at the moment, I think let's first control the outbreak. I think in the aftermath of this, there are going to be issues, there could be reforms, and I agree with you that we need to do that very quickly before we start forgetting this challenge that we are having. I've seen some hands. I don't know whether, Bruce, you can pick two people from the audience. If not, then we move to the next presentations. And colleagues, if you have questions that we haven't responded, bear with us. You can keep resending them. Bukari is taking some in French, and I'm trying to summarize in English. Bruce, can we have a few questions from people who are in the audience? I don't know if it's possible. Can you, there were two hands up. Bruce?
Yeah, Ambrose, I'm not seeing the hands up right now. So if people have a question they would like to ask verbally, please put your hand up again, if you can. And we can...
Ambrose, maybe we can go to the next presentation, and at the end, if we have time, we go for the discussion.
So yeah.
All right, so let's go to the, so please, if put your questions back into your chat room, and if you think we have not answered it, just please remind us, both in French and in English, because Bukari is taking the questions in French and I'm checking. So now we have the final presentations, and this is really very critical as well. So we have 3 sets of presentation: risk communication and community engagement, logistics and supplies, and then sustainability and innovative continuity of care. So I want to hand over now to Suvaji Good or somebody from the risk comms group to make this presentation. Over to you, risk communications pillar, please.
Dr. Good, you are muted. Unmute yourself.
Okay, can you allow me to share my screen, please?
Yes, you're allowed to share your screens as usual.
Okay, all right, thank you. So you can see that?
Very well, please put them in PowerPoint presentation mode.
Yeah, I got it. All right, thank you everyone and good afternoon. This is very important for us to discuss about the risk communication and community engagement. I just want to have a quick definitions so everybody on board in the same understanding what risk communication is about. It is about the real-time exchange of information, advice, and opinions about between expert or official and the people who face the threat. And I think this is very critical part, that how can we make sure that people are informed and make an informed decision to mitigate the effects of the hazards. Community engagement, on the other hand, is involved a lot of numbers of people, especially who are affected, their family members, their influencers, in understanding the risks they're facing and knowing how to prevent and protect themselves and involve them in response actions. That's what we call community engagement in WHO, risk communication and community engagement. And here I'm going to highlight a few types of communities that we should think about. It's not just only the district or rural area, but is also numbers of a social network, urban areas, ethnic groups, formal and informal setting, inclusive of people in a vulnerable state or in a refugee camps and migration. So that's what we're going to encompass. The approach that WHO used for the COVID-19 is first and foremost, we have to understand our audience. Who are we communicating to? What are we communicating to them? And why we want to engage with them, and how should we engage with them? So we have the 3 prongs of the critical approach that we need to work with, is to coordinate and connect with multiple stakeholders and communicate the risks and provide the critical information, including tools, guidelines for people to be able to protect themselves, and also monitor and mitigate misinformation. Like we've seen a lot of rumors and things that are happening around the COVID-19 because of uncertainty. And we need to engage and empower community to take actions, because we realize that changing behavior in COVID-19 is not as usual in other outbreaks. We ask people to change their social norms, their cultural practices that they've never done before, as simple as having different types of greetings, social distancing, physical distancing. You can't go to religious sites. So these are the new norms that people will not be able to understand or have that in mind before. We also want to be able to have people participate and take responsibility in the process. When we talk about the community engagement, often we forget about we have to have the plan. A good plan leads to the good result. Most of the engagement that we observed was not well planned. And here we can say that when we plan, we have to think of the landscapes, what influencing people. In the COVID-19, it's like the tips of the iceberg, just like any health issues. And the COVID-19 keep adding the fear, the uncertainty, the disbelief, the inadequacy of the health system itself, or inefficacy of people and the support measures that can help people to protect themselves. There are several determinants that we have to understand in order to be able to engage with the community. As we said, things that influence people are the attitude toward the risks, how much they really believe that this is at risk for them, what is their health literacy rate, what are the cultural practices, how important it is for being together, for mass gathering, for greeting, what are the gender roles and power dynamic within the communities, the age, ethnic groups, relationship, stigma, all of these can play a very critical role in people perception. We also have collected information to realize that there are also practical reasons. That's why people perceive COVID-19 differently, such as the availability of testing, accessibility of testing, healthcare services itself, and the means for prevention, such as water, soap, alcohol-based sanitization, or lack of information itself. There are numbers of issues around the measures that people felt inadequate. And there are empirical factors that come from past experience with the health service and past outbreak, and the issue of trust. So that's the key elements when we look at the landscapes of what influence people perception. On the other hand, we also have other influence that coming around the enabling factors or barriers in prevention and protection. You have existing economic, political factors, existing inequities. We already seen numbers of areas that we have poverty, we have people living conditions that not allow them to do isolation or keep distance. And also, again, consequence of the past experience. But what's unique in this COVID-19, as it is a pandemic, is the third landscape. It's about the amplifying factors to make this either more positive or negative impact on prevention. You might have heard the word infodemics, the flux of informations that becomes uncontrollable. And for us in the risk communication, it's like we also have to tackling this infodemic besides all the technical experts doing the epidemic control. We have to monitor the mass media social medias, influencers, and propagandas. We also have to understand that around the communities and people in public arenas also have a contradictory beliefs and information that they receive. And sometimes it also related to the mismanagement of preventive measure, especially when we early announce for quarantine or for lockdown and people get a shock and you give no time for them to prepare and have a rational understanding of why they have to have announcements of lockdown. That's an example. What we are facing in COVID-19, the important part, I think, is the urban context. And within the urban context, it poses a different unique challenges, especially the sense of community and individualisms come to play. People perceptions are formed from different entry point, different medias, different networks. And also within the vulnerable situation, people in a settlement, in the low resource setting, we found there is village within the community. There are many villages, in fact, within the urban setting. And we have this kind of social dynamic of people living in a settlement. You have informal workers, you have homeless population, street vendors, street children, and family. How are we going to guide them to take actions to protect themselves, or the government to be able to provide what is necessity for them to take action to prevent COVID-19? Densities, inadequate housing is obvious. And what we need to do, even in the urban context, is to have a rapid assessment that require understanding of the channel of communication, literacy, and where people get the trusted information. Who are their trusted influencer in the urban context? So for us, like many others in the planning, we have to be able to assess the community asset. We can't take community as blank slate. They also have something. They have skills, they have knowledge, they have commitment among the community members, and they have the social support system that can provide a very good access for all the pillars that respond, do contact tracing, or even support isolation, support the quarantine, and help people to help each other for the mental support. There's so many local groups, organization, informal network. We need to know what are the resources, physical resources, environmental resources, economic resources that community can take into their hands and understand how can they mobilize and supply to each other in terms of food, in terms of water, in terms of soap, and other measures that they need to help each other or elderly patients. There are also other external agencies that have been working with the communities. Who are they? How they influence the community? How they can help community, including security forces and law enforcement. We need to engage with them and communicate with them and have them become the partners for community engagement and community risk communications. So there are many tools that are available that I will not go down to it, that I can share with the groups at another stage. For the community engagement, I want to highlight at least these 4 components. Community engagement and communication with the community is not just about telling people what to do and have them participate in a mass gathering, because this is in COVID-19, we can't do that anymore. So we have to make sure that their participation means what type of participation they can do to support the protections of people. What about the peer education? What are the other means of engage with people to have one-on-one contact, telephones, calling each other, sending SMS? How can they build the network and partnership? When you build a network and partnership with the communities, means you have to give the level of capacities to the country, to the community or members of the community, be the youth group, be the women's group, or the community leaders, and all the gatekeepers. And we need to empower the community as a whole. So I just want to keep the 3 bullet points. The critical part in the planning is what are we going to do with the community engagement? What kind of activities? We should emphasize the demonstrations of actions of what people can participate in doing, how to organize a support team during the social isolation, physical distancing, what to practice in public area, what to do at home. And when you have the restricted public mass gathering, what does it look like? How people can still go to church without being infected to one another and reduce the risk. And at the same time, we should also be able to plan for what kind of resources that they can distribute and why these measures save life. And among the communications, we have been promoting that even having information is saving life. Without information, you can't save life. You don't know your risk. The second point is to be able to make people able to take actions and preventing and protecting themselves. Many communities need to have a capacity, and we need to be able to help them to bring the positive measures, even as basic as contact tracing, or bring solution for the basic IPC, hand washing station. What can they do? How can they do it? With the existing assets or additional support. And the third point, in our planning, we should have the build capacity-based network to support the response with the peer-to-peer, women's and elder groups, traditional health practitioners, artists, community health practitioners as well, influencers, local medias, farmer radios. Recently, we repurposed the farmer radios to talk about COVID-19, which is very exciting. And I think this is one way of trying to reach out. But of course, with this COVID-19, there's a lot of misinformations and rumors. So in our guidelines, we also have this misinformation management step-by-steps that we just launched out with the country officers in WHO. So these are the simple 6 steps that we can work with the community, with the government, and also try to mitigate the rumors that coming around the events of this pandemic. So I want to thank you. I think that's within the time frame. Thank you very much, everyone.
Thank you very much, Sivaji, for that. Risk communication is very, very critical, and thanks for being able. Please stay online because I can see so many questions from colleagues. Julian has some comments. I'll summarize them. So let me move to the next presentation. David, logistics. Logistics management is one of the critical pieces of response. So David, please.
Yeah, good afternoon to all. Good afternoon. Do you hear me?
Yes, we are hearing you. Just tell me next, and I will move.
Yeah, my name is Zinedine from OSL. I'm an operation manager for OSL. Thanks to give the opportunity to present the main function of the operation support and logistics OSL. The role of the OSL is to ensure that and operational partners have a reliable operational platform in order to deliver effectively on SRPs and operation plan. The 3 functions of OSL are operation support. Next slide, please. Yeah. The 3 functions of OSL are operational support, supply chain management, and health logistics. Next slide, please.
Consider it, talk closer to the mic, please.
Do you hear me now?
Yes, it is better. So
okay. Next slide, please. Okay, thank you. So the first pillar, the operational support, OSL responds to the operational needs by supporting the implementation of several services, such as office support, team living support, fleet management, communication, etc. And as part of the COVID, we take care of EOC offices, installation of EOC offices, by providing WHO office space and accommodation coordination for the team and partners in the context of emergency, with an access to the IT, to the telecom services. About the coordination with the partner, we support, for example, there is each EOC, there is several commission, and in the logistic commission, we support this commission. And in general, logistic commission are shared by a member of the MOH, the Ministry of Health. This coordination between WHO and the MOH allow us to give the necessary support, such as sharing tools to the Ministry of Health, like supply management tools, fleet management tools. We also, in terms of coordination logistic, we are doing the mapping of the logistic partner, principally agencies of UN, INGO, and we share our expertise in terms of logistics and capacities, who does what and where. We share also the capacity of storage, the warehousing, the transportation, and also the health facility setup and management. Yes, and this commission, this coordination, external coordination with the partner, we take care that there is an agreement on the role and the responsibility of each partners. Next slide, please. So the second pillar is the supply management, supply chain management. The supply chain management activities determine the need forecasting, the supply of medical and non-medical items, the warehousing, the transportation of goods, the coordination with partners in terms also of supply. As part of the COVID, we take care of the availability of the critical supply for health operation and other unit department, like point of entries, detection of potential cases, management of suspected cases, and first action response in case of a confirmed case. For that, we check the availability of also of the MOH level, at the MOH level, availability at the WHO level, in the different hubs we have in Accra, for example, or Dubai. Availability also with the partners through the WFP, UNICEF, etc. And also the availability on the local market. In terms of warehouse capacities, we check all the standards and guidelines according to the storage of the items of the PPEs, for example, or the medicine, by control the temperature, and in terms also the superficie available, and also the staffing to manage the warehouse. The transportation of material and drugs is part of also of the supply chain management. We check of the availability of the means on transport, but also the possibility for rental for transport means. It could be trucks, it could be pickup, it could be cars. And also the last point is the stock reporting and supply prepositioning in the warehouse, and also in the health facilities and treatment center, by setting up monitoring tools and procedure to follow the consumption of all the critical items. Next slide, please. Okay, in terms of health logistics, there are several activities related to the health health logistics, sorry. We are in the health logistics, we talk about the installation and construction of treatment centers, transit center, support of IPC activities, and the water and sanitation, the cold chain or ultra cold chain, the logistic laboratories support, and the sample management in terms of transportation. But the health logistics, the activities correspond to a different stage in the evolution of the epidemic. We have 4 stages: the prevention, the detection, assessment, and the response. The prevention, it's the capacity, for example, for the cold chain management at national level, and a capacity also to timely initiate a vaccination campaign. We have to be ready for this. In terms of detection, the organization and functionality of the main point of entry by providing equipment and to also show the adequate use of PPE with the colleague of IPCs, isolation and treatment facilities at the point of entry, and to set up and also to provide equipment. In terms of assessment, the capacity to diagnose a potential case, the logistics provide the equipment for sample collection and the transport of the sample to the laboratory, and also the capacity to transport this safely and timely, the sample from a district level to a national level if required. It's what we are doing, or we did in the Ebola EVD in DRC. We did the transportation for all the sample from the North Kivu until sometime Kinshasa. It's what we are doing now also in several countries. In terms of response, the last point, the capacity to isolate and treat the patient. We check of the existence of isolation unit and treatment in the district. So we assess with our team, health logistics team, to see how to set up a treatment center. And we check also for the flow of the patient and the health staff. We provide equipment, and we support the colleague of IPC in implementing the measure, etc. When we also identify the seat for an eventual setup of a larger treatment center, it could be gymnasium, as is done here. Field setting up a treatment center with tents. For that, we have person who are in charge of this part, and also the identification of a list of supplies and equipment required for the isolation unit and treatment center, and for a large treatment of units setup, and the availability and adequate use of the PPE. Next slide, please. We also provide support IPC activity. I won't get into the details, but as an example, OSL support wash activities by providing adequate water and appropriate water supply facilities in terms of quality, quantity, accessibility. provide also adequate and appropriate shower and toilets for the health facilities or the treatment center, and provide adequate and appropriate waste management system. Next slide, please. Next slide, please. Yes, this slide is related to the RRT, Rapid Response Team, and we find on the pillar of this slide the pillar of OSL, and this slide explains the role of the logistics within an ERT. We find the 3 pillars of OSL: supply, logops, health logistics, and also the capacity building. All the activities related to each pillar are more detailed, and because it's an operational level. The logistics function enable to the RRT to conduct its mission and find solutions to practical issues. The logistic cannot be improved. It has to be planned ahead, prepared in advance, and HR need to be trained and exercised. The success factor, if we can say like this, for RRT deployment, deployed of the RRT to the field must be carefully planned and prepared. This preparation includes a good knowledge of the context of deployment, a good understanding of the virus and its way of transmission, a clear action plan and SOPs for action to be conducted by RRT, a clear definition of role and responsibility of each RRT team member, and equipment also adapted to the task to be conducted by the RRT and available 24/7. RRT members are trained in advance, and RRT member has to be available 24/7 and at short notice. Next slide, please. So on this slide, you can find the reference documents and support if you need some documents. We stay available for this, and you can also follow the link. We can provide the link of each pillar if needed. And I finished. Thank you very much. Thank you.
Thank you very much, Zinedine and Zinedine. We now go to the final presentation, which is on decentralization, sustainability, and innovative approaches to continuity of care, which is going to be presented by Modrek and Tassis. So Modrek and Tassis, please, over to you, then we go to the Q&A session quickly. And colleagues, those of you who are saying WASH and IPC, Kuten, we have got your concern. We had a session on IPC, but our presenter is indisposed, so we will have to organize another webinar on this. All right, sustainability, please, colleagues.
Ok, bonsoir à tout le monde. Nous allons un peu parler français. Merci pour votre participation. Nous allons essayer de partager par rapport à ces derniers points concernant la continuité des services dans le contexte de la réponse à COVID-19. Je vais commencer par dire d'abord la santé demeure un droit, un devoir.
Health is a duty for the government and a right for the people, and it's also an ethical issue for us as organizer of the health system and health services. It is also important for us to know that access to quality care, responding to the need of people anytime and anywhere, is right. This is what we call universal health care. And when we talk about universal health care in the context of COVID-19, it is important to note that, as all colleagues said, our health systems across the world have shown where their limits are, especially when we look at COVID-19 as a resilient test on our health systems. This virus started off in cities and now it's present in the hinterlands. And now I'm going to talk about the district level, and our response should be dual, because the issue is dual. We have to respond to COVID-19 and along the line also ensure continuity. When you talk about decentralization in the health sector, regardless of the level of decentralization, whether at administration, deconcentration, it is a delegation. In the health sector is per se decentralized. Now, does the district have empowerment? Is it autonomous? That is important, because anything we would like to do, whether we want to organize anything, service continuity at the district level requires for the district to be empowered, to have the necessary resources. Now, let's put community at the heart of everything and we can succeed. Service continuity requires 4 strategies. When we talk about service continuity, we're talking about something that has existed, which will exist beyond the COVID, and it's present during the COVID response. First, you need vigilant leadership and management. Colleagues talked about how we can have the teams work at the district level, but let's be pragmatic and simple. We need local crisis management committees with the local administrative manager who will chair this type of committee, in which the health sector will be the technical assistant. And these committees should be inclusive, should be participatory, and we need to insist on accountability. Also, regarding, we have lost the speaker. The speaker's microphone looks as if it's off. Could somebody unmute the speaker's microphone, please?
Tassis, we can't hear you. Tassis, we can't.
On ne vous entend pas, monsieur. On ne vous entend pas, monsieur. Votre micro est fermé. Allô, vous m'entendez? Nous vous entendons maintenant. I was saying that this is an opportunity for us to work on the fundamentals. In the standard declaration, there are 3 components. There are cross-sectoral actions and policies, and we know that districts are indeed where you can translate policies and strategies into concrete actions. And cross-sectoral approaches is a reality at that level. We have also community empowerment, and we have service provision. So for the first strategy, let me dwell on an important aspect. We need to use the young people sufficiently. We need to use them fully, because I think that Africa has a large proportion of youth, and it is a group within our communities that we should use. We should also say that we need to incorporate the COVID-19 response in the response of the local community services, and not the contrary. We need to integrate COVID in the activities of the local health systems. The second strategy is the following. If we do not have a proper planning to find a space where we are in a scenario, a disaster scenario, well, all the health facilities will be overwhelmed, and we won't have any space for any disease, whether it is malaria or surgery or vaccination. So in the second strategy, therefore, we need to reduce pressure on health centers by identifying in each district schools, churches, youth centers, sports fields, which can be turned into COVID-19 response centers. And at the end, even if we identify all of these sites, we still need to prepare them for use. So for the first step is to identify the sites, but the second step should enable us to transform them. Otherwise, we won't be able to use them. Next slide, please. What is also important is that we need resources. Talking about service continuity means that we need to ensure that the people, the staff are available and motivated. And I think that what is important is to start identifying volunteers now. Let's not wait when we are overwhelmed to start looking for volunteers. Now is the time to identify them and train them and show them what they can do. It is also important to have mechanisms whereby medicines will be available in all health centers, and as well as the equipment. And when talking about equipment, we also need to ensure that we have the PPPs available. All health facilities should be able to respond to the response to COVID-19. Now, we have limited resources. People are talking as if we didn't have COVID around anymore already. We have our health strategies, including activities for service provision. COVID is around, we are responding to it, but let's look at how we can use our plans in our health response and come up with operational plans, taking into account the current context. And the fourth strategy, which is very important, is how to optimize the organization of health services. What is important here is that we need to come up with a list of all our health facilities. That is very important. Once we've done that, that is the first step. Then, from all of these facilities, whether they are private or public, from the police or the army, we need to identify those who can be frontline facilities where we would have the units to respond to COVID-19. Once we knew what these facilities are, we would then equip them. But the other facilities should have also a minimum number of activities related to COVID-19. Whether a small or a large facility, you need to have an isolation spot. In fact, actually, you need to start with triage. We need to have those triage areas. Maybe you can set up a tent for triage. You can set up one way or another using ropes or lines to conduct a triage. You should do it in order to triage the people coming in. It is also important to note that we are learning. We are on a learning curve in response to COVID-19. We have distanciation. We also have other elements like the tools we use against the contagion. Now, people are afraid of going to hospitals, that's what they say, because they're afraid of catching the virus. But I think that what is important is to provide proper information. I think our colleague talking about risk communication talked about it. In spite of the COVID response, facilities are still open and they are still operating. So, based on the measures taken by countries, lockdown and confinement, etc., not everybody would like to go to hospitals, but we have just lost the speaker. Could somebody tell the speaker that his microphone is off?
I think we've lost the speaker because there is power fluctuation going on, so you might have lost it.
Nous avons perdu l'orateur. So,
Tassis, are you still there?
Hello, can you hear me? Says the speaker. We have the speaker back on.
All right, let him proceed. Tassis, proceed, please.
I think that what is important for us to say this, we have the facilities that have been selected to serve as a center. There are facilities that may not have the necessary equipment. This is the second type of centers. Even if you do not have the equipment, you can still ensure that you observe all the measures in order to combat the transmission of the virus. You need to have an isolation spot. You need to make sure that you have the IPC. You need to make sure that you have hand washing equipment, and everybody going through your facility has to be informed. So that is very important. Now, for the facilities in which you would have a proper COVID response units, one needs to make sure there is care continuity. In other words, if there is a woman expecting a baby, you need to make sure that you can deliver a baby in such a facility. If you have somebody who comes in with the COVID virus and with other diseases associated, you need to be able to ensure that this critical disease, for example, is catered for. So that will ensure general case management and service continuity. Now, let me draw your attention to this. The situation may become more difficult. We apologize, there is another interruption. We are asking countries to define the basic package or the key package to ensure that all vulnerable people are covered, including expecting women, children, the elderly, and critical disease patients. Because there are also diseases which reduce immunity. So these people should be catered for. Now, in a given hospital, you don't need to hospitalize the patient who is already contaminated. You need to ensure social distancing. Therefore, necessary hospitalization should take place in hospitals. Now, for health facility visits, instead of having 15 external visit patients, you can make sure that you ensure social distancing. It is better to focus.
Tassis, I'm sorry, you have exceeded your time. Tassis, Tassis, please summarize. You exceeded your time, Tassis.
I think we have suggested that there is a need for a referral system to ensure service continuity system in addition with the COVID situation, and we are proposing 3 possibilities. I would like to close here and give the floor to moderators. Thank you.
Context for the decentralization concept, highlighting some of the strategies for continuity of services. I just want to pick up from where he left and just to highlight the importance of there is background noise. Can the host mute? So I was about to say, I'm just going to highlight quickly some of the innovative approaches that can enable strengthening of the public health care. As you know, that there is increasing activity in the innovation space, whereby there is upsurge of technological and digital innovations. And the advice is for us in the African region to start thinking of leveraging some of these technological breakthroughs, as well as redesigning our service delivery around those innovations, and as well as leveraging some of the care delivery mechanisms through social innovations. For instance, with respect to technological transformation, this is a key opportunity for paradigm shift in scaling some of the public health or primary health care interventions. Take, for instance, there is transition from analog paper registry system to digital records. And this is something that we think should be prioritized. And that digital registry is coupled with some digital records with the mobile application, just to facilitate availability of data in real time. And one speaker spoke about the geographical information system, which is a technology that can also improve surveillance and real-time collection of data. And why I'm highlighting this is just to encourage audience to start also thinking innovatively, not just to stick to the status quo. And while you are in this innovative mode, you start to think also on how to organize even your healthcare workforce. And as you know, that there is availability of information through social media, internet, and all that. So basically, the approach is no longer that one-on-one care provider as it used to be, but patients are somehow empowered. So there has to be a strategy of bringing in patients to the table in terms of decision-making for their treatment or even care options. And there is also an increasing expansion of the spectrum of care. It's not only the nurses, doctors, or health professionals that are providing care, but you realize that there is that spillage to continuity of care even at community-based settings. So I just thought to highlight this example to say if you are starting to think of digitalizing primary health care, these are some of the issues you need to consider. Take, for instance, we now have responsive devices that can provide case detection, diagnosis, care tools, and also you can now have services on e-learning, telehealth. This also can strengthen your case detection, diagnosis, and patient management. And now capacity building at primary health care is no longer as a hassle because you can leverage some of these technologies that are available and also accessing standard operating procedures and best practices. So I feel that it's important for sub-national and district or primary health care level to start thinking of how to integrate some of these innovative approaches. So my last slide is just to highlight what are the strategic issues for scaling some of these public primary health care innovative intervention. So there has to be a deliberate approach in identifying and selecting health innovations based on gaps in health systems and disease burden, as well as just try to do a cost-benefit analysis. At WHO, we are working on a guidance on how you can actually go about this. And the other thing that can attract development and scaling of innovation is you coming up with some kind of incentive mechanism, either fiscal or non-fiscal, to stimulate the availability of some of the innovation that will solve your contextual challenges. And another thing is to establish a transparent funding and decision mechanism to support integration of high impact innovations. And what we also are seeing is there is a non-systematic way or ad hoc basis for scaling some of the promising innovation, and the cost that is associated with scaling ad hoc innovation is quite high. So we are encouraging collaboration across key actors, including private sector and even non-health industry. We need to also encourage setting up of innovation platforms or hub. This is a way to encourage continually infusing of new innovative ideas, and that can be supported and scaled at either district or national level. What we also advocating for is capacity building for health workforce to support adoption and sustainable scaling of these new innovations. Once health workforce are informed, they know the scaling pathway, they know the funding mechanism, they know some of the bottlenecks that is associated or that are associated with adoption and scaling of innovation, they will be in a better place to either encourage or to make that scaling possible. So the main message here is the regional director is being asked I've listened to the interviews by many journalists whereby she's being asked for how we are leveraging local innovative solutions on the continent. And I really want to encourage that we need to start thinking innovatively and also try to cultivate our own homegrown solutions because they answer to our specific challenges. Thank you very much. I think I can stop here. Over to you, Ambrose.
Thank you very much, Moderator. Thank you, Tassis. I hope that the translation is now taking place. We've come to the end of the presentation, so we are going to have some Q&A sessions, and I've captured several, and I want Bukare will also summarize some which are in the other languages. For the risk communication and community engagement, we need to make COVID-19 a business for all sectors. How do we reach out, engage the governments in Africa to make sure that this happens? The second question, Suvaji, was how do we deal with stigmatization? And I think this one is something that you might want to address. And then the third one, we need risk communication for other interventions like immune boosting interventions, eating fruits, nutrition, vegetables, reduction of alcohol, reduction of smoking. What is your strategy to do that? And then Yaguiba said, we need to reinforce a One Health approach. I think this was a comment, but there was also one, we need a lot of capacity building on community engagement in the countries. What are your strategies to do that, Suvaji? On logistics, we are not receiving acknowledgement of the supplies that we have ordered by OCL. What is happening? Can you please explain? And please, will all the countries benefit from the humanitarian corridor being set up by WHO and WFP? Because some countries are not benefiting. So could you comment on that? And then when will the humanitarian corridor start? There is a question that we thought WHO would help with supplies of equipment and PPE, but this is not the case. So can you please explain that, Zinedine? And what is the plan to solve the shortage of personal protective equipment? And what about logistics for provision of essential services? What is happening to that? There was an observation IPC should be presented separately. We take note of that. It was supposed to be presented, but our presenter fell sick. So please, we send our apologies for that. And then from Alex Chimbaru, who was saying the challenge is really now supplies, PPE, medical supplies. This is what the challenge is happening in the country. So Zinedine, please explain something. And then on essential health services, that essential health services should be a pillar of the response itself. This was from Chari Maris. And then reproductive maternal newborn care should really be addressed. What about indicators for nutrition? On innovation, I haven't yet got a comment. So those are the ones that I captured from my side. And Bukare, do you have any? And in which case, I'll call the presenters to respond. Bukare, over to you. Do you have any summarize the questions that you've captured in French?
No, there are more questions. So over to you.
All right, so Suvaji, can you please comment? I hope you've captured my question.
Yes, I got them.
All right, can you respond, please?
Okay, if you remember my first slide that I talk about the goal of risk communications and community engagement is a multi-sectoral partnership. And we have to coordinate and work with other sectors and to make this a priority, because I think whatever you do in terms of epidemiologies and things that we do, if you don't communicate and we don't engage with other sectors and communities, people still don't know what you're doing. So this is what we also need to highlight to the highest level of the government and also make this as a priority, especially when we have the National Operational Committee for Emergencies. The risk communication is part of the pillar and is one of the center focus in many countries. So I think that's what we need to do. What I wanted to address on the issues of stigmatizations, besides having this community engagement, the risk communications also engage with medias, with public relations, and many people to set examples of positive behavior and positive relationship between people on different ethnic groups or different personalities that may be stigmatized of a different background. So we use a positive engagement with the people in diversities and promote the solidarity. The questions on the promotions of immunization, healthy behavior, nutrition, yes, those are part of the package. Besides the COVID-19, especially in the isolations, lockdown period, we keep promoting people physical activity, healthy diet, healthy balance of, on this NCD prevention, because we know that people who have chronic illness also vulnerable for COVID-19. The last but not least, the issues on capacity building. Right now we have a series of webinars with the medias, with the radios, and we also try to get the webinar, and thanks to Bukare, that probably we can launch a webinar also to train our key partners and colleagues on the risk communications and community engagement. And I must tell you that we have a very good package now for African context, which we have been developing since last 2 years. So we should be able to launch it out with the webinar very soon. Thank you very much.
You can announce if you have a date.
Thank you very much, Subaje. We have to end this in the next 10 minutes. So I want logistics to quickly run through in the next 5 minutes, and then Tassis in the next 3 minutes. We need to close this in 10 minutes. So logistics, please, quickly.
Yes, thank you very much. Just about the supply, I don't know if you remember, a few weeks ago, WHO has had warned that severe disruption of the global supply of the PPE, for example, caused by the rising demand, panic buying is so due to this strong demand all over the world since the beginning of the COVID. As you saw also, price have increased. Surgical masks have increased also. The transportation is also a problem because of the closure of borders and airports, the drastic reduction of international flights. Delivery of supplies can take weeks, as we have seen in the recent weeks. For example, last week, for some African countries. Some African countries have been delivered last week, but in the beginning of this week also. To quickly return to the supply chain, the global, on the request of the UNSG and in support of the UN Crisis Management Team, a supply chain task force has been implemented to establish a COVID supply chain management system. This supply chain task force, co-chaired by WHO and WFP, include representation from each participating agency, WHO, WFP, also the funder, the World Banks, Global Fund, etc., who are accountable to deliver on their agency commitment to this critical emergency. There is a document, some guideline that aim to bring clarity on this process, on the process, of requesting and receiving critical supply through the UN COVID supply chain. Finally, I think that I understand very well the concern of African countries, and I propose that if there is some concern and for the delivery and the supply, I propose that each country, each person responsible of this can also be in touch with us directly to see, because each country is a specific problem. So we can get in touch to discuss about this problem and to explain what is going on, what is happened, etc.
Thanks a lot, Zinedine. On the humanitarian corridor, I would like to actually assure you that our regional director and the counterparts in WFP, we're trying to set this up not only for just supplies, but also human resources. So you will be receiving a communication, WR will receive these, and probably the resident coordinators in the countries on the humanitarian corridor that is being set up. Tassis, you have 2 minutes to say something about the essential services being a pillar in response and reproductive, maternal, neonatal, and child health. Tassis, over to you, and then we close.
Yes, before you say, you say 3 minutes. Okay.
I am the moderator. I have the final say on this. The host has to have another meeting. Sorry.
No problem. Let me take this opportunity. Alors, je pense que je suis d'accord avec les collègues qui
I agree with the colleague who said that who talked about mother and child health, and this is one of the priority interventions, so there's no problem with that. Now, secondly, the community agents, we know that they are exposed, and we do not encourage our community health workers to be sent if no measures are being taken to protect them. We also talked about the mobile clinics. These are to be encouraged because it helps us reach the difficult to reach populations. This is where I will end, and thank you very much.
Thank you very much. Moderator, you didn't have a question, but very valid issues.
There is one comment from RMA, which I think is very important.
Okay, say something.
Yeah, the demand has always been present. Africa needs solutions that will sustain over time, and that can be adapted to our realities. So I think this is a very, very key. I totally agree with RMA on this. The issue hasn't been the supply or the lack of supply for innovation. The issue has always, or the barrier has always been the scaling side of things. So if at country level or at district level or at primary health level, we don't have a mechanism that we can put in place to facilitate that scaling to happen, we will be losing a war, basically. So I think what is encouraged is for either at district level or at national level to come up with some kind of a coordination mechanism that include all the stakeholders or the key stakeholders in the ecosystem space to facilitate that scaling of health innovation. Over to you.
Thank you very much, Moderator, for those. And please, colleagues, I think we've come to the end of this session. Please, we know that there is a lot of need for credible information, and we're going to continue with these webinars. We have one planned for nutrition, and I would like to thank our co-host, University of Mexico, the ECO Project, the professional associations, Dr. Were, Bruce, Juta, and of course our technical capacity building officer Bukari for organizing this. We want to support you. We count on you in the countries. Please stay safe. From me, the moderator, I please give my panelists a virtual round of applause. You don't have to clap. You don't have to clap virtually. So final remarks from housekeeping from Bruce and Bukari, if you have closing remarks for the next webinar.
Just quick housekeeping from Project ECHO. Just thank you for the amazing presentations to all our presenters and for the great participation from across Africa. We'll be sending an email in the next day or two that will have links to all the presentations and a link to the recording. So everyone who registered will get a follow-up email with links to all the resources. Thanks everyone and stay safe.
Merci beaucoup tout le monde.